International Congress, day number 2. So I hope you all have a nice sleep and you're ready for some new adventure. We have 11 new debates, and trust me, they're all very great, especially the last one. To wake you up, because I see that some of you are really sleepy or at least look a little tired, I had a special, a gift for you, but unfortunately we cannot make it. So I'm going to present you my gift after the debates. Unfortunately, I'm sorry about that. So it was about a drama club. But okay, let's carry on. Now I would like to just start and open the Congress and invite the first debate titled, Should Endovascular Treatment Intervention for Brain Aneurysms Be the Treatment of Choice? Presented to you by Asma Hallab, I'm sorry if I pronounced it wrong, and Tomislav Felbabić. Asma Hallab from Faculty of Medicine, Pierre and Marie Curie, Paris 6, France, and Tomislav Felbabić from Medical Faculty, University of Ljubljana, Slovenia. And of course, under the mentorship of Assistant Professor and Neurosurgeon Boštjan Matos from University Clinical Center, Ljubljana. Now, I would like to invite Dr. Matos, if you could join me here by these very seats for chairmen. Thank you.
Okay, so hello everybody, I'm Tomislav, this is Asma, and today we would like to talk to you about should endovascular intervention for brain aneurysms be the treatment of choice. At this point, I would also like to thank our mentors.
Yeah?
Does this work? Oh, no, it doesn't.
It doesn't.
Okay, at this point I would also like to thank our mentors, Dr. Boštjan Matos and Dr. Dimitrij Lovrič, for helping us with our debate and for being with us here today. So, let's get started. What exactly is an aneurysm? An aneurysm is a vascular disease characterized by local dilation of arteries. Basically, it's some sort of a bulb or a bubble that forms on the arterial wall. It forms because the wall at that spot is weakened, so the high pressure inside the arteries pushes the wall outwards. Why exactly is the wall weakened is not yet certain. Some say it's genetic, others say it's local inflammation, but that's not really important for this debate. It's not a rare condition. Autopsy reports have shown that approximately 5% of human population have a brain aneurysm. But it is important to emphasize that 5% of people die with the brain aneurysm, but not because of it. The incidence is highest in 30 to 60-year-olds, and it's more common in women by the ratio of 3 to 2, and it's rarely seen in pediatric population.
So, in this slide, we will see that there are several criteria to classify aneurysms. As you can see, there are different forms. The saccular form and the fusiform forms are the most common ones. The size is also important to mention. For example, for the giant aneurysms, which have like 2.5 centimeters of diameter, they can have large neck size and they may involve more than one artery. In these studies that we are going to see also, the size of the neck is important to mention. And when we are going to talk about aneurysms, we are going to especially talk about unruptured aneurysms, but we should also know that those unruptured aneurysms could also rupture, but hopefully the unruptured ones are more common. So in this picture, we will see the most common locations of aneurysms. 80% of them will form in the anterior circulation, while only 20% of them will form in the posterior circulation.
So what are the risk factors? Risk factors can be divided into congenital and acquired. Congenital would be family history, Marfan syndrome, Ehlers-Danlos syndrome, polycystic kidney disease, neurofibromatosis type 1, etc. And the acquired would be smoking, excess alcohol consumption, obesity, arterial hypertension, and so on. So symptoms. As we have stated earlier, approximately 5% of people have a brain aneurysm, but most of these people are asymptomatic. Symptoms do occur when the aneurysm grows so large, it starts pressing against other structures, which is called symptoms by mass effect. And these symptoms are nerve palsies, anisocoria, which means asymmetric pupils, double vision, headache, and if the aneurysm ruptures, then the symptoms would be severe headache, nausea, vomiting, and loss of consciousness.
So the main diagnostic procedure for both cases are CTA, MRI, and catheter angiography, which is the best. Most people find out they have an unruptured aneurysm fortuitously during a brain procedure for some other pattern. Ruptured aneurysms has poor prognosis. 50% of people don't even make it to the hospital. Between 30 to 40% of people will die in the hospital within 30 days regardless of the treatment. Others, survivors, will be left with permanent disability. And here we can see some rupture predictors, like the size of the aneurysm, unruptured aneurysm, the age of the patient, the pre-existing familial condition, the hypertension, and smoking. So for this reason, treatment is not only indicated for ruptured aneurysms, but also for unruptured ones, either to prevent the high risk of rupture or to relieve the symptoms of the mass effect.
But before we start with the treatment options, first we must mention that not all aneurysms need to be treated.
And here we start with the first endovascular procedure, which is coiling. So the first recorded endovascular treatment of aneurysm was done in 1939. Over the years, the procedure had developed until in the early 19th, Guglielmi and all combined the concepts of electrothrombosis and endovascular approaches to develop the detachable coil system. Guglielmi detachable coils were approved by the Food and Drug Administration and formed the basis of contemporary endovascular treatment of intracranial aneurysms. Here we're going to see the steps of this procedure in the following video.
In this animation, we see the aneurysm as a bulge upon the blood vessel located just behind the right eye. Aneurysms have thin walls and can rupture and bleed, and for that reason we want to treat them before they bleed. We can put a tube up through the patient's circulatory system to the artery that's affected, and then through that tube we can take a microcatheter, or a very small tube, all the way into the skull, through the affected artery, and into the aneurysm. Once that little tube is into the aneurysm, we can then insert some fine platinum wires or coils that are sized to fit the aneurysm and pack the aneurysm tightly so that the blood can no longer enter into the aneurysm and thereby reduce the chance that the aneurysm can expand, rupture, and bleed.
So, as final result, we can either obtain a complete occlusion of the aneurysm or an occlusion with a residual neck. Fail refers to a residual aneurysm. So in a study done by Muriyama et al. In 2004, we got complete occlusion at about 55% of rate. And the same exact study was done also by Gonzalez et al. In 2004, and we obtained also 55% of complete occlusion.
Yeah, but if you look at this study from a different perspective, only 55% of people treated with endovascular coiling are completely cured. Those 35% of people who are left with neck remnants will most likely get recanalization of that aneurysm since it wasn't completely excluded from the circulation. That means that those 35% of people will most likely have to go through another procedure sometime in the future. And let's not forget about those 10% of people not mentioned before whose results were even more unfavorable. That means 35% plus 10%, 45%, that's almost 50%. It's like a flip of a coin of patients treated with endovascular coiling will have unfavorable results and will most likely be subjected to another procedure. And same goes for Gonzalez et al. Study.
Yeah, true, 35% will be left with the neck remnant, but in the exact same study it was also noted that only 10% of them will have to go through the procedure again, and that means 3.5%. Plus the 10% of unfavorable results, and that makes 30% of people who got be retreated and not 45%, and this is an enormous difference. And let me tell you also that even though the treatment is relatively young, it has become one of the treatments of choice for the brain aneurysms. For example, in this study done on the middle cerebral artery aneurysms, which generally this surgery remains the treatment of choice. Here we have in this study the embolization was favorized on the other options of treating. And during the procedure done on 51% of people, a high number of them got no complication at all. So,
well, that may be, but the complication rate is still relatively high. 25.5% is particularly alarming when we see 3 ruptures and 10 thromboembolisms. Makes you really think twice about its safety.
Yeah, true, but that was in 2007, and the procedure has evolved more and more after. And when we see that we got 42% of complete occlusion in this study, we can deny the benefits of coiling.
Yeah, but we still decry big numbers of residual aneurysms and residual neck cases in this procedure.
Yeah, true, but in this study we recorded the improvement of the occlusion rate in 7 patients. Moreover, no bleeding or rebleeding were observed during the period of follow-up, which also highlight that coiling treatment gives lasting results.
Well, I guess you got me there, but I'm still not quite sure about endovascular coiling. I still think that surgical clipping would be a better option. So what exactly is surgical clipping? Surgical clipping is the oldest method used for treating brain aneurysms. The first surgical procedure done on a brain aneurysm was done in 1931 by Norman Dott. Then, in 1937, Walter Dandy placed a silver clip across the neck of the posterior communicating artery aneurysm. The goal of the operation is to completely exclude the aneurysm from the normal circulation. This is done by first opening the skull, a procedure called craniotomy, and then placing a small titanium clip across the neck of the aneurysm. The procedure has several steps, as we can see here, and here's the short animation of the procedure.
An aneurysm is really a balloon on a blood vessel, and as it balloons out, it becomes thinner and thinner. When the inside pressure in the balloon exceeds its ability to contain the blood, it will burst and the aneurysm will bleed. The whole point of clipping is to prevent further hemorrhages and eliminate the balloon on the...
Okay.
Oh. Okay, so here we see postoperative aspects of clipping. So we see an aneurysm, a bubble, and a clip that is pressing its neck. So here we see 2 pictures of preoperative and postoperative states. In pre-op, we can see that the aneurysm is filling with blood, and in post-op, we see that the clip is completely excluding that aneurysm from the circulation. Surgical clipping leads to better results than coiling. In a study done by Raftopoulos et al., they treated 101 aneurysms. All of these aneurysms were deemed good candidates for either clipping or coiling. So 42 of them were treated with coiling and 59 with clipping. For coiling, total obliteration rate was 56.1%, subtotal was 14.6%, and 29.3% of patients failed the procedure. On the other hand, for clipping, the total obliteration rate was 93.2%, 1.7% of patients failed the procedure with subtotal obliteration, and only 5.1% of patients failed the procedure. There were also some permanent complications in 10% of patients who were treated with coiling, but only in 1.7% of patients who were clipped. In another study done by Tan et al., they figured out that the recanalization rate was 20.4% in coiled aneurysms, but for clipped aneurysms, they have only 0.26% annual risk of recanalization.
Yeah, but there are some other predictors for recanalization. As you can see, there are the large neck size, the wide neck morphology, and the large aneurysm diameter.
True, but this is not all. In another study done by Thornton et al., they treated 1,569 aneurysms in 1,370 patients over the period of 20 years, from 1979 to 1999. In all of these patients, postoperative angiography was performed. In 82 aneurysms, that's only 5.2%, residual filling was found. That means that 94.8% of all aneurysms treated with clipping are completely occluded after only 1 procedure.
Yeah, but what about the risks of operation? We all know that open-head surgeries are more prone to swelling of the brain, to vasospasm, to infection, to bleeding, to seizure, to stroke.
Well, of course the operation carries some risks, but every operation does. Even appendectomy, one of the oldest procedures, still carries some risks. Completely clipped aneurysms have an extremely low risk of regrowth. But true, if the aneurysm isn't completely clipped, then the patients will have to go on periodic follow-ups to make sure that that aneurysm isn't growing back. On the other hand, coiling also carries some risks, like, I don't know, thromboembolisms, bleeding, rupture, incomplete occlusion, and coil protrusion into the parent artery. The latter is very probable if the neck of the aneurysm is too wide.
Yeah, but in those cases, there is another procedure that we can use. It's called the stent-assisted coiling. So this stent-assisted coiling was approved by the FDA in 2002. It is generally used with the wide neck, giant, and fusiform aneurysms. And this stent, which we are going to put, will prevent the coil from going inside the parent artery. And here we see in this video how it will be. So, in some difficult situation of coiling, we'll see how this stent can help from protrusion of the coils inside the arteries. Up. So, in this study done by Lovrič in 2009, we used the stent-assisted coiling in 32 patients, and we got a complete occlusion in 79%, and only 9% in neck remnant, and 12% of cases were unsuccessful.
Yeah, but you forgot to mention that after the procedure, patients will have to take clopidogrel and aspirin for 3 months, after which, sure, clopidogrel can be discontinued, but they will have to take aspirin for the rest of their lives. It's relatively a long time. Not to mention, if the aneurysm ruptures, or the patient suffers from another illness where aspirin is contraindicated, that would complicate things considerably. Clipping, on the other hand, does not need any medication, and patients will have to go on checkup only a few times after the procedure, after which they're completely free as if they've never even had an aneurysm.
Okay, but you know, progress is being made more and more to improve the outcomes. Thus, we can't approach the endovascular treatment without mentioning the new endovascular procedure called flow diversion. It uses a device called flow diverter. It is like a stent, but unlike stent, whose main function is to maintain mechanically the vessel walls open. Flow diverters will act on the fluid mechanics of the blood, and it will divert the fluid from the aneurysm into the vessel. We'll see on the video how it will work. So finally, the blood into the vessel, into the aneurysm will clot, and it will shrink slowly until the aneurysm disappears. We have here a study done by Lily Cantor in 2009. We used the flow diverter on 63 patients. We got immediate occlusion in 80% of patients. After 3 months, we got 56%, and then 93% after 6 months, and 95% after 18 months. This study was done on small aneurysms with a diameter about 10 millimeter.
Interesting. This flow diversion really shows some promise. So to conclude, both endovascular coiling and surgical clipping are the methods of choice for when it comes to treating brain aneurysms.
Yeah, and as we have already seen, the therapist selection depends on many factors, such as the indication for the parent artery occlusion, the comorbid medical conditions, the aneurysm size and location, the technological advance, the follow-up imaging after coiling. So, for example, nearly all patients, older the age of 16, will be treated with aneurysm in the posterior circulation are better off treated with endovascular coiling, except for PICA, which is better treated with clipping because the surgical exposure is minimal in these cases.
And younger patients, those with the aneurysm in the anterior circulation, are actually equally well treated endovascularly and surgically. But since surgical clipping does not need any long-term follow-up, that should be the method of choice used in those cases. Flow diversion is good for those middle zone cases where neither clipping or coiling are the most viable options. But as we have stated earlier, it's a relatively young procedure, and more research needs to be done to know for sure. Till now, the issue of surgical versus endovascular has not been addressed by any randomized trials for unruptured aneurysms, in contrast to ruptured aneurysms, for which randomized trials have shown the superiority of the surgical clipping. Thank you for your attention, and are there any questions?
Thank you for this fascinating and interesting debate. Now, first, I would like to ask mentor Dr. Matos if you have any comments or is there something you would like to add?
Well, first, thanks to the organizers who invited me to this ambitious conference. And then, of course, congratulations to both presenters. I mean, this topic is very complex and you presented it very well, so I'm just astonished, in fact. So, what to say? The treatment itself, it is dual. It can be done surgically. We did it in the past, and we do still. But nowadays, well, nowadays that means in past 5-10 years, this endovascular treatment is more and more popular. But we decide to treat it. I mean, the treatment is chosen individually. So in every case, we discuss, in every patient who needs this treatment, we discuss whether clipping or endovascular treatment is more appropriate. A lot of factors count, but a lot of them were presented today. A lot of them weren't because it's not enough time, in fact. But of course, what you presented is actually the very important thing. What counts in the treatment, in the decision of treatment. So I'm ready to answer your questions if I will know.
Hello. I'd just like to ask, what is the actual ratio between endovascular treatment and clipping in Slovenia?
At the moment, I would say that it's about 80 to 20 in favor of endovascular treatment. But let's say that all posterior circulation is endovascularly treated. Mainly the aneurysms at the region of middle cerebral arteries are clipped. And more complex aneurysms, which could not be treated with endovascular treatment, are clipped. But it's in general 80 to 20 at the moment. But I think that in the future, maybe this ratio will get more into the favor of surgery.
I have a question for Asma. Well, you said that I think in most of the research, only 55% of the coiled aneurysms were completely occluded. But wouldn't you agree that it's actually a pretty low percentage?
Yeah, like Tomislav said, but you know, in this study, Gonzalez and also for Murayama, 2003 and 2004, it was also noted in the same study that we got 86% of complete occlusion in small diameter. That's why we say that coiling will be left for the small diameter aneurysms, and for wide neck size aneurysms, we will use more stents with this procedure.
I have also one more question, maybe for your mentor. I'm not sure, but since there is always a risk of rupture of the aneurysm during the procedure itself, it seems to me that you know, if you're doing it endovascularly and the aneurysm ruptures, then you're in a big problem because you have to, I don't know, open the head to stop the bleeding. And if you're doing the open surgery, maybe you can stop the bleeding and do some intervention faster. Wouldn't that make it safer in a way, even though it's more invasive? Thank you.
Yeah, that's one of very important concern, in fact, because although the let's say endovascular treatment is called like you know minimal invasive treatment, but the problems or the risk that could happen during this procedure could be fatal, because if the rupture occurs during endovascular treatment, the rupture of aneurysm, actually you cannot help much. So, in terms of surgery, if the rupture happens, you can control this bleeding. In fact, you have a possibility control to stop this bleeding, to clip the aneurysm, to clip the rupture, not immediately, but you know, in a next moment, in the next minutes. So, in fact, this is one of the biggest, let's say, concern. What could happen, or what we can face, but anyhow, you know, endovascular treatment is called minimal invasive treatment. So it has some advantages, but it has also very severe disadvantages which could happen.
I was also wondering, since you mentioned the stent-assisted coiling and like these flow diverters, are there in use in Slovenia? Have you used them?
Yeah, of course, they're more and more used because this technology with endovascular treatment is improving very fast. So that's why more and more aneurysms are coiled. You know, these aneurysms are simple or could be also complex, very complex, with wide necks, with different sizes, with the involvement of important vessels. So all these aneurysms need, I mean, special decision before treatment. So in that terms, we decide, as I said, about every case. We discuss about every case what kind of treatment could be best for this. For certain aneurysm. Of course, especially when aneurysm has a wide neck, or flow diverters, or stent-assisted coiling is performed. Also, recoiling is done, and things like this. So this is, you know, the procedure is not, let's say, a single session could be repeated after control imaging and so on. But in fact, the technology goes on, and you know, we as surgeons, in fact, are at the moment in some cases in the second line, you know, because interventional radiologists say, okay, look, we can coil this, we can coil this. So, of course, we can oppose to them, we can clip, but on the other side, in general, this treatment is called minimal invasive. It has some, it is faster, let's say, it is more and more, at the moment, as I said, a lot of aneurysms are coiled.
Just one question. Do you think, in your opinion, that endovascular treatment would be the only choice in the future due to the technological advances? Is that a possible prediction to say? Or surgery would always have a place in treating of cold aneurysms, so not the emergency treatment?
Well, it's not a question of cold or rupture aneurysms, in fact. Also cold aneurysms, so this is cold aneurysms are aneurysms which are found incidentally before they rupture. And also these aneurysms should be treated, whether surgically or endovascularly. But let's say that let's say the simple aneurysms could be coiled and could be surgically treated. But the question remains in a complex aneurysms, where, let's say in complex aneurysms where now technology, endovascular technology, does not have a final answer how to treat them. In these cases, still surgery is the only option. And I think in the future, surgery will still be an option in any case. As we heard today, there are many pro and contra for both of modalities, but in fact, I think that surgery is, I would say, beneficial, but it's in many cases. But of course, it depends on many factors, also on the factor of surgeon. Because treating aneurysms, I mean, surgically treating aneurysm is quite demanding, not quite, very demanding surgery. So the surgeon must be very skilled instead of, let's say, endovascular treatment, which is, let's say, much easier to do.
Okay, unfortunately we ran out of time, so here I would like to conclude this debate and express my gratitude to both two debaters. So thank you.
You're welcome. Thank you.
And now we're coming to the second debate of this session, titled "Surgery is the only successful option for treating drug-resistant epilepsy," by Gašper Zupan from Medical Faculty, University of Ljubljana, Slovenia, and Laurin Burla, Faculty of Medicine, University of Zurich, Switzerland, by the same mentor. Dr. Lorber, could you come up and join us here? Thank you.
So, ladies and gentlemen, good morning. I would also like to say hello to everyone who is watching us over the internet. First of all, we would like to thank our mentors, Dr. Matos and also Dr. Lorber, for being here, for all the help. And also, we would like to thank the organizing committee for giving us the opportunity to discuss such an important topic as epilepsy surgery is. Epilepsy is a common disease with a prevalence of 1% worldwide. 20 to 30% of patients with epilepsy are considered to be drug resistant, which basically means that anti-epileptic drugs which are given to them are not effective. The fact is also that most of that people will never become seizure-free if they would stay just on anti-epileptic drugs. And if you imagine, as hard that it might be, that you have 30 to 40 seizures per day during the day, also during the night, that you cannot, for example, do sport, you cannot go out, you cannot get a proper job, you cannot drive a car. All this represents a big burden for the patients with epilepsy. And the fact is also that people with epilepsy have lower quality of life. Of course, money should never be the issue in medicine, but it is. And let's be honest, all these drugs that we are using for treating drug-resistant patients are basically wasted money. Drug resistance is defined internationally by as a failure of two schemes of anti-epileptic drugs. That means that you give a patient one or two drugs, that doesn't matter. Then you increase the dosage of the drug until the side effects appear. And then you withdraw the drug. And when you did that 2 times, you can say that that patient is drug resistant. You don't have to wait years, you just have to follow this definition. If you look at the screen, here you see in the temporal lobe, you see this hyperintensive area. This is hippocampal sclerosis, which is basically a scarring of the hippocampus. This is the most common pathology among people that undergo operation in adult population. This can cause, but not necessarily, epilepsy. And in some cases, people patients with hippocampal sclerosis also have epileptogenic area in temporal lobe. This is PET scan showing hypometabolism in the temporal region. Of course, PET scan is not the diagnostic tool for saying this is epileptogenic, but in the case when we have this combination of hippocampal sclerosis and malfunctioning temporal lobe, the patient is an ideal candidate for standard temporal lobe resection. This is the right hemisphere. Also, these are the pictures of the right hemisphere, just intraoperative pictures. If you're the surgeons and I am the patient, and I will be positioned like this, and you would open my skull, you would see my brain like this. So the patient's nose is here, so just for orientation. Here, you also see the Sylvian vein. Sylvian vein is positioned in the Sylvian fissure, and this is considered to be the superior border of resection. And this continuously vein is called vein of Labbé, which goes somewhere like here, and it's a maximum posterior border of resection. Of course, usually we never go till the vein of Labbé. The resection is usually measured in centimeters from the temporal pole. So in the dominant area, in the dominant side of brain, we cut 4 centimeters from the temporal pole, and in non-dominant area, we cut 6 centimeters from the temporal pole, as you can see on this picture. Why we cut less in the dominant area? Very logical, I hope, because in the superior gyrus of temporal lobe, there is area of Wernicke, which is very important. This operation is very successful. This is the figure that shows long-term seizure freedom, more than 5 years, 5 years, 10 years seizure freedom in patients. And in our case, in temporal lobe resection, this seizure freedom is achieved in approximately 70% of people, which I think shows a big success of epilepsy surgery, and my opponent will have quite hard battle to prove that wrong.
Well, dear colleague, these numbers here are quite good, I have to admit. If we look to the other numbers here on the top, it's far less convincing, I would say.
It is, but it's still better than than having seizure and having almost 0% chances of becoming seizure-free.
Well, let's have a look at what other options do we have. I would like to introduce to the audience this friendly-looking man, who maybe wouldn't remember you 60 seconds later. He's maybe the most famous example for complications after epileptic surgery. He's known as patient H&M. He had severe tonic-clonic seizures when he was younger, and I know it's an old example, but it perfectly illustrates some problems. In 1953, he went to the hospital, and his surgeon only suspected, without any further diagnostical methods, only out of the clinical picture where the origin could be, and took out both hippocampi and some other structures. So this patient was after this had an almost seizure freedom, but at the same time had a severe anterograde amnesia, a memorizing time of 60 seconds, and ended up with 54 in the nursing home. You see the question, severe epilepsy or memorizing time of 60 seconds, what would you choose? It's not only important to know exactly where the origin is and if there is an origin or if the origin is generalized, but also if we're really dealing with epilepsia. So let's have a look at differential diagnosis. And here I found a really interesting review article. You see there are several other causes for potential seizures. We have neurocardiogenic, we have migraine, aura, cerebrovascular seizures. For me, very interesting is this psychogenic origin, the dissociative disorders that also can cause seizures. So this is the review article. 20 to 30% of patients referred to an epilepsy center for refractory epilepsy receive the diagnosis of dissociative seizure. So I think you can see that it's really important that you have a really good evaluation. Otherwise, you give to these patients for years drugs that they actually don't need. Maybe a small additive information, how you can differentiate between epileptic seizures and dissociative seizures. The VEEG is a method where you have a video of a patient during seizure, and at the same time you have EEG, and in the dissociative seizure you don't have abnormal activities on the EEG. So let's have a look to complications after temporal lobe surgery that you mentioned before, with 66% of 5 years seizure freedom. 18% developed de novo psychopathology after temporal lobe epilepsy surgery. Why is this important? Because we need to include a neuropsychiatric assessment to increase the prognostic models and to know what's the outcome, or try to know the outcome after temporal lobe epilepsy surgery. What other complications do we have? We have about 11%. To mention some examples, we have motor deficits, cranial nerve deficits. We have up to 55%, dear colleague, visual deficits that can range from small triangular defects to a complete homonymous hemianopsia.
Yeah, but even if this number is right, the 55%, which I doubt, it's much lower, most of these defects are, in fact, small defects, are quadrantianopsias or even less, and most of the patients don't even notice them. I remember one study, there were 45 patients that were giving a post-operative ophthalmological examination, and just one, after a years of surgery, and just one patient actually complained that he had some symptoms of that. So it's, in most cases, it's asymptomatic for the patient.
Well, dear colleague, this number is from this review article, so it's correct for sure. The question is, of course, if it's predictable before the surgery, if you can predict what kind of visual defect you will have at the end. Let's mention some other complications: language deficits, especially word-finding deficits, and memory deficits. Again, the pre-surgical evaluation is very important. If you have a patient with a contralateral dysfunction of the hippocampus and you take the one hippocampus out, you have a patient with a high risk for severe anterograde amnesia.
Well, yeah, all this is true, basically. The side effects are a possible option. But what we can do, if the patient is, of course, a suitable candidate, is that we do more selective procedure. Here I'm showing you the selective amygdala hypocampectomy, so the removal of amygdala and hippocampus alone. We have three approaches, basically: transsylvian, subtemporal, and transcortical. Transcortical is shown in these pictures. As you can see, the skin cut is quite small. I didn't mention it before, but for example, in the standard resection, skin cut is usually question mark shaped, is bigger. Then we open the skull and we go through the middle gyrus of the temporal lobe to the area of interest, and we remove it. And you can see that this removed area is big, just, I mean, it's fairly small, just few cubic centimeters. And we know for a fact from research that these methods are as equally effective as standard resection in, of course, patients where the epileptogenesis is somehow present just in those structures which we remove. Of course, if there is some area that's also malfunctioning in temporal lobe, in the cortex, this procedure will not be effective. We also know that volume of resection does not correlate with outcome, and some studies also shown cognitive sparing.
Yeah, but dear colleague, how is the improvement in visual defects?
Well, yeah, okay, there is no significant, statistical differences were found, but it's true that if you, for example, use this approach, subtemporal approach, you basically avoid the the optic radiation, and therefore this approach, subtemporal approach, is, for example, one option in case if you don't want to risk visual field defects.
Okay, but nevertheless, it's not always a simple case, and it's not always to remove and detect the region. The cortical dysplasia is the second most common pathology in epilepsy surgery in adults. So what if, here is the problem, when the lesion is very near to the cortex? It's not always that easy.
Well, I say that we should use the surgery first. This and this picture are showing something that we call map of the brain, cortical mapping. Here we basically stimulate the cortex, and we see which areas of the cortex are responsible for which function. It's the same here, just that here this is done with transcranial magnetic stimulation. Functional MRI is the same. It's the same principle. Here, this gentleman, in this case, was actually asked to move his thumbs, and you can see which areas are responsible for that function. We can also do the tractography. These are not strictly surgical methods, but are very useful in determining where the lesion is. But one method that's surgical is awake surgery, where the patient is aware and it's also cooperative during the surgery. You can also do the brain mapping during the surgery. And you also know how much to resect because the patient is responsive. So this is an option in that case.
Yes, but what do we do when the lesion is inside the primary motor cortex, for example? I mean, because of different problems, 14% of the refractory epilepsy patients remain polytherapy candidates. So let's have a look at the situation in the moment with anti-epileptic drugs. We see here that in the last 20 years, the majority of the anti-epileptic drugs came out on the market.
Yeah, that's true, but they're still not really successful in treating drug-resistant epilepsy. So.
It's a significant improvement. We're getting better, I would say. Yeah. So let's have a look at the less invasive methods. We have vagus nerve stimulation, we have gamma knife radiosurgery, and we have radio frequency ablation. Of course, there are more methods, but we will mention these ones. Vagus nerve stimulation is quite a famous option. Here we have two possibilities. We have the invasive one, where you have an intrathecal stimulation device that's mostly connected with your left vagus nerve. Or then we have the transcutaneous device that's like an earplug. It's a new device called, it's newer than the invasive device called NEMOS. That stimulates your ramus auricularis nervi vagi and goes to the nucleus tractus solitari that's associated with anticonvulsive effects. So these are two possibilities. The transcutaneous one with the earplug, the dose is about 4 hours a day in spreaded sessions. You should use it. It's 43% of seizure reduction. It's a safe, economic, and widely applicable device, and especially in the point widely applicable, it's in contrast to neurosurgery, I would say. The invasive vagus nerve stimulation device, after 2 years, we have about 45% of seizure reduction.
Yeah, but there are also side effects of vagus nerve stimulation. They're, of course, connected with the innervational area of vagus nerve. So basically, they're quite common, to be honest, but basically they're connected with the function of laryngeal muscles, but they are present, so.
Yeah, that's true.
It's annoying.
We have another option, it's gamma knife radiosurgery. This is an interesting method. It's not invasive, it's extremely precise, and the beams do not harm the healthy tissue because the beams are not strong enough, and in the target they get powerful and they can destroy the origin of epilepsy.
Yeah, and also this is a good thing, yeah, about this fast decline of the strength of the radiation. But the truth is also that there is a limitation with the maximum diameter of the target. The biggest lesion that can be treated is 4 centimeters in diameter. So this is a big limitation of gamma knife.
You're true, it's a big limitation. It's also for special indications. Here a paper that's about insular cortex epilepsy, where it's a quite promising method. Another option would be the radio frequency ablation that we don't perform in Zurich at all, but some papers have shown that it's for sessile hypothalamic hamartoma, associated epileptic seizures. It's a quite good method.
Well, one option is also deep brain stimulation. In Parkinson's disease, it's very successful. In epilepsy, it's not so successful because we don't know where exactly we should put it. Most of research are considering as a target areas the limbic system. Here, for example, this X-ray showing the electrodes in the hippocampus. The success rate of DBS in one big study where the electrodes were put into the anterior thalamic nucleus was that there was 55% median reduction. So 55% of people had a median reduction in seizure. But DBS is a viable option.
We have some complications, if I can mention them. We have about 15% of depression and 13% of memory impairment.
Yeah, of course, that's a consequence of the constant stimulation, but there are also new methods of DBS where the stimulation is not constant, but it's produced just when the epileptic attack starts. So it's so-called open-loop devices.
So let's have a look at the future, new approaches. There has been shown an association in between leukocyte vascular interactions and increased number of seizures. So this would be, or is, a potential target for new drugs. And last but not least, the take-home messages. So surgery is the best solution for carefully chosen patients with refractory epilepsy, exclamation mark after carefully chosen, and we do not have to leave patients alone on drugs, especially refractory epilepsy patients who are not candidates for standard resection. You've seen we have some other promising methods, and the multidisciplinary approach in epilepsy centers is also very important. So thank you very much for your attention.
Thank you for another fascinating and interesting debate. Now I would like to ask the mentors if they have any comments or any messages they'd like to add.
Well, thank you very much. It was a very nice overview of the surgical option of the treatment of epilepsy, although you were not really very much against each other. I mean, you came to the same conclusion at the end. The surgical option is here. It's not here only for, I mean, it's here for decades. You've seen the age, I mean, the year 53 with a big complication, but the very beginning was, I think, 23, 24, and it was developed and in Canada, went up through the Second World War, and at the end of the World War II, it was well-established treatment. So this is not a question whether to do it or not, it's just a question when and on whom, and what way, what can we improve. And thank you, yes, I mean, the conclusion was the same as I would point to everybody. But you are a surgeon.
Yeah, of course I'm a surgeon. Well, treatment epilepsy is actually a complex stuff, let's say, and one of the options is also surgery. But of course, if there is indication, so first of all, the right, the right patient or the chosen patient should be the right patient should be chosen. So not in that case, diagnostic and this complex diagnostic must be performed before, and then the decision for the surgical treatment is taken by neurologists, neuropsychologists, and also neurophysiologists and neurosurgeons.
So you mean it's the prerequisite to go with the epilepsy surgery to sit together like we sit now?
Yeah, in fact, with cooperation, with constant cooperation, that's the only way that we can do something in favor to help patients with epilepsy.
Any questions from the audience?
So we're in this crazy super modern times that surgery is more or less becoming more and more obsolete because we're thinking about new types of models on interacting at molecular level, more or less. Okay, maybe for now we don't have the data on specific treatment for refractory epilepsy or something, but do you think that surgery is going to stand as a gold standard for this, like forever? Or at least in the next 50 years, if my lifespan is 50 years from now? Thanks.
Well, epilepsy is a very mixed bag. You have lesional epilepsy where the surgical approach is obvious. You have a benign tumor, you have maybe a cortical dysgenesia, very spotted, then it's probably always an option to take it just out. Maybe to disconnect it somehow, functionally, maybe in future. Well, imagine some kind of a device that you go directly there non-invasively and just disconnect pharmacologically, possibly, so that you will not attack the whole brain with some kind of a molecule, but just a certain part of it. But we are far from that. I just recently came on the spot of the paper, which is not published yet, on the EEG that is, for example, made intravascularly. So you just have electrodes with a nanotechnology just traveling through the vessels to the target, and then the very precise recording is done. Of course, the treatment can also be transported to the target this way. But this is a very, very basic research at the moment. We are not getting there in clinical, I think, in 10, 20 years.
Well, if I can add something, in my opinion, I think that especially in lesional epilepsy, or where the focus is known, the development in the near future will go in less and less invasive methods. For example, I think that just a few months ago, a paper was published describing the endoscopic approach to the temporal lobe. So I think this is the near future for the lesional epilepsy.
Oh, yes. I mean, the pre-surgical investigation should become less and less invasive. Yes, it's true. So if you have, let's say, 20% of all epilepsies as candidates for surgery, you would harm them if everybody has some kind of invasive investigation before the surgery. If at the end, let's say, 5% can be treated, why just not spare these invasive procedures to those 5% if possible?
I have just a small comment, because they use the case of HNM or HM, the patient who had to be by temporal epileptic places. So I think this
is not true. He has a bilateral dissection.
Yeah,
for no obvious reason. Epilepsy actually came from one. The second one operated, not the first one.
Yeah,
so
that's
it was a mistake.
Yeah, that's what I wanted to say, that they don't do bilateral dissections anymore, just because of these patients. They realize that it will cause, how to say, memory loss. So they don't use it anymore. It was this patient, and then they stopped that, if I'm not mistaken.
Well, to be honest, there were another, I think 8. There were 9 altogether. Surgically treated on both sides, just HM became so famous.
Yeah.
Of course, I mean, neurology learned a lot, and not just neurology, maybe psychology, psychiatry, from epilepsy surgery. Of course, there were mistakes, like those in HM, but it's pretty far, I mean, it's 60 years ago.
Yeah,
I hope we are not doing them anymore.
No, of course not, but I think in a debate where we have more or less 20 minutes time, it's a good example, and it's more impressive than maybe 10 slides or I mean, it's an example that you will remember. And
I will refer even to your slide, I think number 3 or something, when you had the MRI and the PET scan.
PET scan, yeah.
The PET scan result.
It was his slide, yeah.
Can you just show them again?
I don't know if we can.
Is it? No, we are over. Here we are. Look at it. The PET scan. What do you see in this PET scan? Some red dots, aren't they?
The inactive places on the temporal lobe, the blue places.
Well, yes. This is what I want to point out is a danger that someone examines the very fancy new method and sees something which is not connected to
the other parts.
What we're looking for. And these red dots have no significance in this PET scan at all. But of course can lead someone, or may even be there for, I don't know, for dual pathology. Something else may be there but not relevant to epilepsy. So there's always a danger to approach surgically to a certain region in the brain unnecessary. Well, we don't do these mistakes like taking both hypocampi out anymore. But there are other dangers here. So still a work for a group, for people that look together into the brain images, either radiological or physiological, and decide together what we're looking for and what is safe to operate on. So it's a teamwork.
Yeah. Also, he said, he talked about the hemianopsia, and he said it was a complication of the operation. But now I think there is the tractography, and they can limitate those cases and avoid to make a lesion on those tracts, I think, or what we call them, the optical devices. Yeah.
I don't really know why this happens still, but it's considered as a very common side effect, and it's not even called a side effect anymore. It's just when you have this approach to this temporal region, it's expected. But it's usually, as Gašper said, a minor degree, very minor degree. It's not a heminopia, it's quadrantonopia, and even less than that. It's upper. And as he said, patients very often do not notice that.
Yeah.
It's only obvious in the direct examination.
And it's avoidable with the new procedures of imaging.
I would guess yes, I'm not a surgeon.
Okay.
Unfortunately, we ran out of time again, so I would like to conclude this debate and this session. So thank you both of your debaters. Thank you, Dr. Lorber. Thank you, Dr. Matos. Now I guess my gift finally arrived. So do you guys need a minute or two to prepare? Okay, a minute.
Okay, should we begin with the 8th session? Okay, and the 8th session is the second part of medical ethics. And I would like to invite the mentor, Professor Borut Škodlar, to the table. And on the pro side, we have Sara from University of Ljubljana, Slovenia. And on the contra side, we have Kirsten. Was it right? Kirsten from the University in Nijmegen, Netherlands.
Yes.
I hope I got it right. Probably not.
So, hi guys. This was a nice introduction. Thank you. Our debate goes off in a little bit of a different tangent than what we have heard so far. We will be talking about suicide prevention and whether we should or should not prevent it at all costs.
But my life too is threatened at its very root, and my step is unsteady too. Does anyone know who said these words? By a raise of hands. Yes. Who was it? Or? Speak up. Yes.
Just change positions.
Yeah, sure.
Oh. Okay. I didn't really hear, so anyone can speak up if they want. Van Gogh, yeah, correct. There is no lonelier man in death, except the suicide, than that man who has lived many years with a good wife and then outlived her. Anyone? Who said these words? It was Hemingway, yes.
Well, our debate will not be based on these topics on presentation. I'm so sorry of too much, but I would still like to start with this introduction about what suicide really is. It is death caused by self-directed injurious behavior with any intent to die as a result of the behavior. And we should all note that it is not an illness in itself, but a process that has usually been started long before the actual death. The global burden of suicide is actually really high. I was surprised when we researched for the topic that it is among the top 20 leading causes of death globally for all ages, and among top 3 for people who are aged between 50 and 45. Every year, nearly 1 million people die of suicide, and it is also important to notice that the incidence of suicide has increased for almost 60% in the last 60 years, globally. But in the European Union, it has decreased for about 20% in the last 10 years.
So suicide is a common thing, as I just showed you with these famous people who have actually committed suicide. In order to answer the question of whether we should or should not prevent suicide, it's, first we can ask ourselves the question, can we prevent suicide? And we won't go into the risk factors and prevention strategies since we only have 20 minutes, but there's one message we would like you to take home, and that is that 50% of the people who commit suicide have been to their GP's office the week before they committed suicide. So that's quite a high percentage. And the same is for 80% of the people that commit suicide have been to their GP's office 6 months before.
From our medical standpoint of view, one of the most important questions regarding suicide is whether there is a psychiatric disorder underlying every suicide, or are there perhaps some other reasons for suicide as well that we will touch later on in our discussion. We should know that in about 90% of people that have committed suicide, undiagnosed or undiagnosed psychiatric disorder has existed. Depression raises the rates of suicidal behavior for 20 times, bipolar disorder 17 times, and substance abuse, Slovenia high, for 10 times at least. Up to 80% of people who have committed suicide have had several depressive symptoms during their year leading to suicide. One of the most important things with regards to depression is the fact that it is commonly underdiagnosed in the elderly, and that they also manifest the depression with physical signs rather than just psychological signs more commonly than in the younger population. Also, the lifetime risk of suicide among people with other mental disorders, such as schizophrenia, is significantly higher.
But suicide does not always result from a psychiatric disorder. It's also important to look at other aspects, such as severe physical illnesses. 25% of people that commit suicide suffer from a painful and severe physical illness. And in the special population of elderly people that Sarah just mentioned, it's 80%. And then a footnote on actually Sarah's behalf is that people suffering from a physical illness rarely commit suicide in the absence of any psychiatric symptoms.
But as we have promised, we have some other points of view on suicide besides our typical medical. And we would like to present to you some of the main philosophical thoughts on suicide. First of all, I would like to all of you to notice that during the history and all the way up to the Enlightenment period, most of the philosophers who have thought about suicide more profoundly have been in accordance with the Western religion point of view on suicide, and that is that suicide is sin. It has not been until Kant, who is a German philosopher, I guess that you're all familiar with him, from the Enlightenment period, who has thought on suicide on another level too. He was really famous for his dissertations on morality, and his basic premise on this view of suicide has been whether the person who commits suicide would be willing to universalize the act of suicide. Therefore, if I was to commit suicide, was I willing to say that everyone can commit suicide, therefore? And because if I would agree with that, the humanity and society in itself would cease to exist, he was really strongly opposed to suicide per se. One of the other philosophers who I would like to present to you was Mill, who is a British philosopher. He is particularly interesting because he has had a few arguments both for pro-suicide and contra. He thought that killing oneself should be prevented mainly in the order to avoid precluding the ability to make further choices for this person. Therefore, I should prevent someone from doing suicide, committing suicide right now, because if he commits suicide right now, he won't be able to make his own choices later on in life. And the last but not the least is Camus, who is a French philosopher, and he was one of the leading philosophers of existentialism. He thought that suicide is the rejection of freedom, and that the absurd man who has embraced his freedom would live without any prospects just for the sake of living and the freedom that it brings with it.
So yes, while there have been many philosophers that have argued for prevention at all costs, there have also been many philosophers that have argued against prevention at all costs, one of which was Schopenhauer, a German philosopher. He says that if someone is destroying their existence as an individual, they are not destroying their will to live. In fact, they would like to They would like to live if they could do so, but the circumstances are just too strong for them. And then, as Sarah just said, Mill also offers a counter-argument. He says, he uses the example of a man that's about to cross a bridge. So we can warn this man of the dangers of crossing the bridge, and we can ask him, or maybe we should tell him to stop. But in the end, we should not prevent him from crossing that bridge, because only this man knows the worth of his own life balanced against the dangers of crossing the bridge. I strongly believe in my next argument. It's one that is an argument of liberalism, and it basically states that suicide is the most basic human right of all. Someone should be able to make their own decisions, and someone else should not force their own ideals onto someone else. Someone should be able to make their own decisions, and those decisions should be respected. And then we can also look at other cultures, such as a form of suicide from Japan that's called seppuku. This is viewed as an honorable way to redeem oneself from personal defeats. It was viewed as brave rather than cowardly and wrong, and it was only reserved for the samurai class.
Well, now we have covered the psychiatric point of view, and we have covered some of the philosophy. And for the last part of our debate, we would like to point out some other reasons for suicide and our thoughts on it.
Some people say that suicide is never the answer. But what if, for the people that commit suicide, it is the only answer? It's a reason of last resort. It's the only answer to their either emotional or physical problems. Should these people be forced to suffer unnecessarily? Should we prevent them from making decisions over their own lives? I would argue we should not do that.
But on the other hand, there is this possibility of advances and new treatments in medicine that we are all aware of all the papers that are coming out all the time. And the question here would be, should the patient always wait just a little longer, you know, to get a little better antidepressant, antipsychotic, a little better pain treatment, or maybe also the possibility of gene therapy, because recently there have been some papers that have established the possibility of genetic traits as predispositions for suicide. For example, higher level of methylation of the BDNF gene in the brains of suicide victims, also lower levels of serotonin in the CSF of suicide victims, and also the fact that monozygotic twins have up to 17-fold times bigger chance of suicidal behavior if their twin has committed suicide. But here I agree, and I'm sure that Kirsten thinks that it is hard to draw the line where it is a part of genetics and where it is a part of family and the social system that surrounds these two twins, for example.
So as a last argument, I would like to point out that this is an international congress. So let's not just look at Slovenia or Holland, where I'm from. For example, let's look at Switzerland, where they have physician-assisted suicide. I believe that if a person is able to make an informed consent, they should be able to make decisions over their own lives.
First, we should do no harm. I guess that most of us are familiar with that. It's part of the Hippocratic Oath, and I guess that is one of the main arguments against physician-assisted suicide or euthanasia clinics that have been established throughout some of the European countries. But I would also like to point out the fact that since euthanasia is not legalized in most or almost all European countries, it has become a profitable business in those countries that have legalized it. For example, there have been a few reports of the Switzerland clinic that has had the physician-assisted suicide, that the doctors have taken money specifically from the patient in order to get the treatment of choice, therefore the drug to kill oneself. And the question here would be, if we would ban euthanasia, would we stop this profitability of the business per se? Or on the other hand, if we would establish euthanasia in all of the European countries, would that lessen the profitability and therefore give us the chance to decide basically only on the moral and on the medical grounds? I guess this was it from us. So do you have any questions? Would our mentor like to comment on anything?
Thank you. Thank you for really well structured and brilliantly presented arguments. Just 2 points just to pose the discussion. First, what we need to bring into our picture when discussing suicide of a person or potential death of a person is people surrounding him. There is a clear datum that at least 7 people after each suicide are devastated after the death. And that's, I think, a very important issue. It's not that that could be, of course, only argument contra, like other people would suffer, then you should not die. Of course not, but still a very strong one. And then another thing, just to bring in another philosopher, Nietzsche. He said in one of his notes that thought of suicide saved many of his desperate nights. Maybe we should take into consideration that thinking about committing suicide and so is also an entrance point to a discussion to
consultation to therapy, psychotherapy in the end. As Viktor Frankl, that you might have heard of him, Viennese psychotherapist, said and pointed many times to let's think of the point of no return, point of death, point of suicide, and think back to the present situation where we are and what we'll decide from this perspective, the end one. Just to underscore again, the thought of suicide is not only a danger, it is a great danger, of course, and we need to take it seriously, but it's also an entrance point for a discussion, for helping people that are in such a situation. Yeah.
So, thank you to both girls, and thank you, Professor Škodlar. So, are there any questions?
Hello, yes. I would like to ask if it's suicide may be genetically predisposed. So I've been aware of in my country there was this case that one of the family members committed suicide and then another member after that committed suicide, but it was like 10 years after. Or is it like that act of the family member just a path that the other members choose to end their depression or something, or some problems they have? So are you aware of this? Is this common or not?
Oh. Was that directed to the mentor? Or
to the mentor, yeah.
I didn't, can you just repeat once more?
Is suicide genetically predisposed?
Well, yes.
Are you aware
yes,
of those?
Of course, I mean, there's no doubt. There was pointed to in the discussion, yes, there is a genetic contribution, let's say, to a suicide. Of course, it is said that about 40 to 50% of almost can be explained by genetics, though I believe it's less than that. It's, of course, the statistical constructs that lead us to, but there is no doubt that there is a genetic factor. But as you know, there is a multifactorial, as in every mental disorder and many other disorders that we treat, that there are so many factors, and that means also that there are sporadic suicides in families where there is no suicide. And there are people, like I treat a patient who is whose 4 members of the family committed suicide, and I don't think he's suicidal or of course he's out of that. It's only a massive trauma that we need to deal with. So, yes.
Thank you.
Hello. Well, first of all, I think we should separate euthanasia from suicide in other conditions, because it's really quite different. For example, in patients who, are subject or wish euthanasia, those are terminally ill patients who do not have any future potential as far as medicine and knowledge goes. But once I heard the statistics, and I'm really not sure if that's correct, and I would like maybe if you know, if you could share the information that in, not terminally ill patients, but other people who tried to commit suicide but were saved, that in 5-year period after that, like 90% of them were still alive. So they obviously changed their minds about wanting to terminate their life. So maybe it's wrong, but I would really like to know. It would really, I think, make a difference. Thank you.
Thank you.
Yeah. If you have any thoughts, just... well, there is a diverse statistics on the issue. There are 2 points. Attempting suicides, so suicide attempts is a danger of a future suicide, no doubt about it. Statistics show that. But it's also true, it's not 90%, less than that, but that many people after, it's all depends on other factors, as I've been mentioning, personality traits among them, impulsivity, aggressivity, and similar are among the highest, who then choose or decide what will happen afterwards. There are many patients, many people who, after a suicide attempt, do radically change their position on suicide. They would never do it again. They might be even advocates against it or helping other people not to go into that direction. But there are some who with the impulsivity, as I mentioned, and other personality constellation that do not allow them to kind of see other solutions and other ways out of the suffering they are confronted with. So, yeah, it's on both sides, but the statistics is diverse from each point of view you see. So both is positive. There are, as I mentioned, many suicide attempters who will end up with suicide, and many who are on completely other side of the river.
Can I say something too? Yeah, because I had the same thoughts as you had. But since the title of the debate was "Prevent Suicide at All Costs," therefore I don't think we should prevent it at all costs. Because yes, of course, some people attempt to try to commit suicide and then are happy that they live and never try it again. But I don't think that is for everyone. So we shouldn't prevent it at all costs. Not, yeah. So, yeah.
I'd like to throw around a couple of ideas and possible suggestions. Where does free will come into this? I mean, if free will is the arche of every person, that's the primal right of every person, and you have a great quote there from Star Trek. Where do we displace human rights as a free will in order to subdue it for the benefit of the community or something? Where do we as a community say that this is right and this is not right? Your free will is not really free will because it's not right for us. Anybody can join in.
Yeah. Anybody can, that's true.
And I'll make another comment.
Did you mean by that whether the culture or the community has a right to impose somebody not to die by suicide?
Yeah.
If that was the question.
Of course, yeah.
Where is his personal freedom in all that?
Yeah.
Would any from the audience like to comment on that?
So, who will try
to make to reverse the sides? How do we? Should we enable or provide life at all costs? Not to take it for a suicide, but should we enable life for any cost?
The reversal of the question doesn't help, yeah. It's the same question.
Maybe,
yeah.
I suppose you could argue that people who have suicidal ideation and would like to commit suicide because of psychiatric illness which can be treated, such as depression, those ideations are not their free will. It is the illness that is taking away their free will. And yeah, but I'm not saying at all costs, but I was also wondering, is it like the error in the method itself, since suicidal ideas are themselves like a psychiatric symptom? Does it then, should it be excluded then when saying how big of a proportion of, suiciders had psychiatric illness? Is it actually less if you take out the suicide itself as a symptom of a psychiatric illness? Yeah.
Yeah, you just said that suicidal ideas are a psychiatric symptom. That's not necessarily true. So as Sarah said, it's 90% of people that commit suicide have a psychiatric disorder, so that leaves 10%. So do those people have a free will or not? Yeah, I guess, yeah, opinions differ. Yeah, exactly. You could argue over that. I think they have a free will, and Sarah probably thinks they don't.
No, actually, I do agree with you, although I would like to point out, as Professor mentioned in one of his emails, he mentioned the personality disorders, let's say borderline personality disorder, that has a significantly higher rate of suicidal behavior, ideation, and also of suicide attempts. And when a person has a personality disorder, it is not like depression that is, let's say, easily treated. It is a disorder that persists throughout most of his or all of his life, or maybe we could say all of his adulthood. And where is his free will? Because in most of the time, and most of his ideas and most of his thoughts are, we would not say per se that they are symptoms of a psychiatric disorder or that he has a mental illness, but what would happen if we would enable or if we would prevent his suicide at all costs, and should he have the free will to commit suicide because he knows that his personality is quite unchangeable, or should he be prevented at all costs? If you guys have any opinions.
I would also comment on something. As you have said, the suicide is most likely to be performed by somebody who is depressed, schizophrenic, or alcoholic, or something. So these are all diseases. Yeah. So not treating suicide would be the same as not treating, I don't know, Parkinson's patient with the dopamine. Wouldn't you agree?
Well, yeah, I agree that you should treat a disease if there is a disease, but not everyone that commits suicide has a disease. So yeah, of course, you should treat people that have a psychiatric disease, and they should, I think, that they should, you should try to prevent suicide for those people. But the people that don't have a psychiatric disease, or the people that have lived with a psychiatric disease for, let's say, 30 years, and they are just truly unhappy, and there is no perspective for them, I don't think that you should stop those people from committing suicide, because it's their lives and they are not happy with it. So.
But do you truly think that somebody who's completely healthy would be ready to take his own life?
If it's their decision, then they get, yeah, so they get to make the decision, yeah.
I don't know if you guys have heard of altruistic suicide. The suicide, well, this is more on Kirsten's side, but we have decided long ago that our views are kind of similar. So the suicide where one takes his own life in order to enable a better life, or at least enable a life as it is for other people. I don't know if you guys remember from history lessons, let's say the Irish hunger strikes from the year 1981. It was because of the Irish Republican Army and some of their soldiers were imprisoned, and they went on a hunger strike, and 20 of them died with that. But on the other hand, this was one of the turning points for the whole idea of independent Ireland. And the question here would then be, were they right? Should they prevent them? They did try to forcibly feed them, of course, but in the end, 20 of them actually committed suicide by starvation. But it was, in a way, altruistic for the other people of Ireland, for their common people. So where would you stand on that? Because I don't think that 20 of these soldiers were psychiatric patients or mental disorders.
I think that's the same line of reasoning that terrorists apply in their attacks.
Yeah. But they do have a free will.
Yeah. Well, yeah, so the needs of the many outweigh the needs of the few. Maybe you agree or you don't. Yeah.
Now we were talking about like therapy options and prevention and stuff like that. But I would like to ask, since you mentioned it in the presentation, that a lot of those people go to the GP before committing suicide, if there are any signs, or how can we recognize those people, if there are any common symptoms or something like that?
Yeah, so we left that out of the presentation because we only had 20 minutes, and there are a lot of risk factors, such as, yeah, like our mentor just said, people that have attempted to commit suicide are more likely to try it again or even commit suicide. And there is actually a mnemonic for the risk factors. I know the mnemonic, but I don't think I can name you every risk factor. The mnemonic is sad persons, actually, so that's how I remember. And maybe Sarah can help me, but it's, for example, it's, so the S is sex, either male or female, because males have more, the chance that a male commits suicide is higher. Then the A, I forgot the A.
Then we also
age,
yeah, and we have a really important part of the suicidology is also the prevention in the context of the social settings. And the social groups and mainly the safety nets and the connectedness and people's interactions with other people are really, really important in the prevention of suicide, because most of the people who have committed suicide have been on the outer verges of society. They have not been integrated fully or as well as most of us are. So that is also one of the important
things. And also availability of mental health care, also a good one. So yeah, there's a long list, and yeah, as a GP you can be aware of that.
It's such a short time for these great questions, but yeah, mostly people who, there are some signs, and there you can find them. It's important to know, as any doctor actually, to know people, for example, that withdraw a bit, change a bit in the last time, and especially take care of saying some last words to some important people in their lives, or taking care of their money or things like that. These are kind of signs that he's contemplating something important in his life, and such. These are signs also that should be taken care of.
Okay, thank you everybody for commenting. Unfortunately, we have run out of time, so if there are any more questions, you can ask during the break. And once again, I would like to thank to both presenters and to the mentor. And
Hello everybody. First of all, I'm sorry for my voice, but I'm a bit sick and I'm on NSAIDs. And now we would like to discuss and find the answer on the question, are NSAIDs legitimately one of the most commonly prescribed drugs? First, we have some questions to you. Who of you have ever experienced pain? Just raise your hand. Who of you have ever taken some painkillers? Yeah, as you can see, everybody, or almost everybody. So we see that it's very important and serious problem, which we should discuss. And NSAIDs are one of the most commonly used drugs for this indication.
Well, let us first shortly review what we know about mechanisms of action of non-steroidal anti-inflammatory drugs. NSAIDs work by inhibiting cyclooxygenase. That is an enzyme that converts arachidonic acid to chemical mediators, namely thromboxane, prostaglandins, and prostacyclin. And there are two types of cyclooxygenase, type 1 and type 2. The COX-1 is constantly present in various tissues, and the mediators that are synthesized play a physiologic role in platelet aggregation, protection of gastric mucosa, and also vasodilatation. On the other hand, cyclooxygenase type 2 is only present in inflammatory states, and the mediators that are produced are important in sustaining inflammation, pain, and fever. And according to that, we know two types of non-steroidal anti-rheumatic drugs. The non-selective NSAIDs work by inhibiting both of these enzymes and thus preventing all of this action. On the other hand, there are also COX-2 specific inhibitors, or COXIBs, that specifically inhibit cyclooxygenase type 2 and thus prevent especially inflammation, pain, and fever.
In last years, we are the witnesses of the big debate about use of NSAIDs, but are they really the most commonly prescribed drugs? Let's take a look at the list of 10 the most commonly prescribed drugs in the United States in 2012. Can we see their NSAIDs? No, but they are still one of the most commonly prescribed drugs among drugs mentioned here, like other painkillers, statins, antiarrhythmic or antihypertensive drugs.
And here on this graph, we can see the trend of prescribing painkillers. We can see that in recent years, the prescribing of NSAIDs has been decreasing. And on the other hand, there was increase in prescription of other painkillers, especially paracetamol and weak opioids. And I believe there must be a reason for this change.
To fully discuss the topic, we should focus on main indications for use of NSAIDs. One of them is treatment of acute pain like injuries associated with infections or the common headache which we all experience. And what the patient wants when they experience that. They want to treat the pain as fast as possible for the lowest possible cost and to prevent the relapse of the pain. And for that indication, NSAIDs are one of the best, if not the best, drugs. Let's take a look on some data about the most common causes of acute pain. It's usually postoperative pain, where the NSAIDs show favor in comparison to other drugs, with number needed to treat around 2.5, 2.7. The other good indication is dysmenorrhea, where the NSAIDs are also very effective. In that study, it was also proved that NSAIDs, in this example ibuprofen, it's almost twice better in relieving pain than paracetamol.
Well, I can believe that, but still we couldn't ignore the fact that the study also focused on paracetamol. And it concluded, firstly, that the paracetamol was as effective as non-steroidal anti-rheumatics for treating of acute postoperative pain in orthopedic surgery patients. So as effective as NSAIDs. And secondly, there was a lower incidence of side events in patients that used paracetamol in comparison to that used NSAIDs. And if you really want to use NSAIDs, then at least think about combination of NSAIDs with paracetamol because their effects are additive, and we need lower doses of both drugs to reach the same effects. And according to that, the incidence of side events is also lower.
Yes, you might be right, but there are also discussions about use of opioids among the people who are pro-use among people who are contra NSAIDs. But let's take a look on the results of the meta-analysis of many different clinical studies comparing use of opioids and NSAIDs for treatment of acute renal colic. We see the favor of NSAIDs in reducing pain among patients in that group.
Well, sorry to interrupt you, but these differences here are not so significant, if you ask me.
Maybe they are not so significant, but we haven't seen any study which is in favor of opioids. But we should also take a look into the results about relative risk of developing side effects, which also shows that NSAIDs are safer and they are the best choice for treatment of acute pain.
Well, I give you something for that, but still we will talk about side events later. Let's first talk about chronic pain. What happens if condition is prolonged, like in osteoarthritis or rheumatoid arthritis or other musculoskeletal diseases? For now, the NSAIDs are considered the first-line treatment in treating of chronic pain, and only when condition progress, we should use mild and later strong opioids, and only then, when the pain is becoming untreatable, we should use additional methods of treatment. But here we can see in this graph, again, that the incidence of prescribing NSAIDs has been decreasing, even for conditions such as rheumatoid arthritis. And I believe if NSAIDs were so great, then this incidence should be increasing.
Maybe you are right, but the main reason is the change which we observe in the drugs which are used in treatment of osteoarthritis or other rheumatoid diseases. We observe the big increase in number of the drugs. This is modifying anti-rheumatoid drugs. And since we use them from the beginning of the disease, we can reduce use of NSAIDs, but it doesn't say that NSAIDs are bad in that indication. They are still good as a first-line treatment.
Okay, that might be one of the reasons. But still, NSAIDs poses a great risk for toxicity, especially gastrointestinal, cardiovascular, renal, and hepatic toxicity. And if we look at this graph here, we can see the number of deaths that are contributed to NSAID toxicity in comparison with other also quite relatively common diseases. And that is not so low number, if you ask me. If we focus on gastrointestinal adverse events, these are by far the most common adverse events that come with NSAIDs. As much as 60% of people who take non-steroidal antirheumatics on a regular basis have problems or symptoms of dyspepsia, nausea, and abdominal pain. Of course, you may say these are not really important problems, but they can progress to endoscopic ulcers, and that can progress to complications, such as bleeding and perforation. And these are harmful conditions that people can die from. And not only the NSAID-related gastropathy, but in recent years, there were many researches on NSAID-induced enteropathy, because they estimated that almost 1/3 of people who take NSAIDs had endoscopic ulcers in intestine, and that can also progress and make another problems.
Of course, you're right, we cannot neglect the data, but we should also bear in mind that the gastrointestinal side effects usually occur in patients from the group of with risk factors, like age, previous upper gastrointestinal diseases, use of multiple NSAIDs, concomitant diseases or drugs, but we always can prevent it and still stay with use of NSAIDs for those patients. The most common prescribed drugs to prevent the gastrointestinal adverse events are proton pump inhibitors or other gastroprotective drugs. Use of them in last years caused the decrease of incidence of upper gastrointestinal tract complications. Maybe there is a slight increase of lower gastrointestinal complications, but in general we can conclude that we significantly decreased level of side effects.
Well, I'm sorry to interrupt you here, but with these gastroprotective agents there is another problem, and that is patient compliancy. Because people who take NSAIDs usually don't feel the adverse events on the first day of their treatment. And they many times don't think that it is important to take also proton pump inhibitors because they have no problem with that. Not yet.
But we still can deal with NSAIDs, stay in that group of drugs. We have another opportunity, which is called selective COX-2 inhibitors, which consumption is increasing in last years with decrease of use of non-selective NSAIDs. So we can use them in patients who are non-compliant, have more risk factors in from gastrointestinal point of view.
But that sounds completely logical, of course. That's great. Use that and we eliminate the gastrointestinal adverse events. But unfortunately, the COX-2 selective inhibitors carries a greater risk for cardiovascular adverse events, especially for myocardial infarction, heart failure, and also stroke. And if people take also other drugs like antihypertensive, there's a greater risk for uncontrolled hypertension. If you look at this graph here, we can see the risk of death or another myocardial infarction in people who took NSAIDs in comparison with people that didn't take that. And here you can see there is a significant change. The risk is greater here. And I'd like to stress that we should be really careful if we really want to prescribe NSAIDs for our patient. Well, we should first assess the risk factors for gastrointestinal and cardiovascular side events, and on that we should decide if they really need NSAID or if we should avoid them. Here we can see that people that are on high risk for developing both side events, we shouldn't prevent NSAIDs if possible.
But still in the group of patients with high risk of cardiovascular complications and gastrointestinal, we still can use NSAIDs. There are some safe NSAIDs like diclofenac or naproxen, which used with the PPIs, are also effective and very safe.
Well, but we should also always think about alternatives. Let's say about paracetamol that we also mentioned earlier. That is a great combination. That is great as just paracetamol or a combination with weak opioids or also with NSAIDs if you really want. And we shouldn't be afraid of using mild opioids earlier in treatment of acute pain.
Opioids.
Sorry.
Yes. Opioids, the most common argument of NSAID opponents, but let's take a look on the data about treatment of adult older people with arthritis. We see that we can compare the toxicity of opioids when they are used for the prolonged condition, like around 1 year, that the number of patients needed to harm is decreasing much faster for opioids than for COXIBs. There are also other side effects which are more common among patients who take opioids than NSAIDs, non-selective or selective. Let's take a look on composite cardiovascular events, composite fractures, or all-cause mortality. In all three cases, we see that opioids shows much higher level of complications.
Well, by now you heard many arguments pro and con about prescribing NSAIDs, but we should also bear in mind that people also take over-the-counter medicine. And they are not well aware of risk factors, of risk that NSAIDs bring. Here we can see that only 65% who are prescribed NSAIDs were also warned about potential side events by their healthcare provider. And even worse data is that only 2% of people who take over-the-counter medicine, NSAIDs, discuss that with their general practitioner. And because people usually, or let's say, commonly combine over-the-counter medicine with prescribed medicine, we should know that there is a risk they don't know for the risk factors, and they don't discuss that with nobody.
If we take into account all Clara's and mine argument, probably we won't be able to find the answer on our question which we set in the title. But we can draw some recommendations. First, we should, as a general practitioners, think about the patient, the risk factors which they have, and the drugs which they take at the same time with NSAIDs. We should also explain the patient the possible side effects, the possible methods and tools to deal with them, and educate the patient about over-the-counters. In general, if we prescribe NSAIDs, we should prescribe them at the lowest effective dose for the shortest period of time. Thank you for your attention.
Yeah, thank you for the great debate. I think that you both gave us a lot of information. and that we should be more cautious with prescribing analgetics. And I would like to ask the mentor if he has something to say.
Well, congratulations to both of you. You were very good. I think that, of course, we can use non-steroidals, but not, as you said, for a long time. And we should warn the patient. We should carefully select the patients to which we prescribe non-steroids. But if we have an older person and he really needs a strong analgesic, I think that opioid is the right choice.
Thank you. And now the questions from the audience.
Hello, I have a question for your mentor. When talking about only analgesia, so only the analgetic purpose, not the anti-inflammatory, I never understand why is paracetamol so completely separated from non-steroid anti-inflammatories, because I know it doesn't have anti-inflammatory action, but it does work with COX-2 inhibition, doesn't it?
No, it doesn't. Not in that doses that we use in a clinical practice. If you are using experimentally higher doses, then yes. But the mechanism of action is different, so that's why I think.
Okay, but I think I read a research that examined whether paracetamol has any of those side effects that COX-2 inhibitors have, and they mentioned that it might have some. So is this only in really high doses? Or?
Yes. We still don't know how paracetamol is working. Maybe there is a COX-3 somewhere in the brain or in a central nervous system, but we don't know exactly the path like we know for non-steroidals.
Okay, thank you.
Hi, what about, I don't know if this was mentioned, paracetamol and liver damage?
Okay, there are many suicides with the paracetamol every year in Europe. You know, if you take about, let's say, 40 tablets, you can die from paracetamol, you know. But in principle, if you don't have any liver problems before somebody is prescribing you paracetamol, then there shouldn't be a problem. Maybe you should do some liver tests on, let's say, regular basis, every half a year or so, but it shouldn't be a problem. Because I think that if somebody is taking it regularly for a longer time, he cannot take 4 grams per day, but let's say 2 grams. So there is still a reserve.
What about if we have a hypothetical patient with cardiovascular problems, gastrointestinal problems, and liver damage? What should we use?
Opioids.
Opioids.
Hello, I have a question regarding COX-6. In what type of patients should we use these COX-2 selective inhibitors?
Mostly we have a patient who has risk factors for gastrointestinal complications. Then COX-6 are safer, but they can do more harm on if somebody has, let's say, hypertension or something wrong with the heart.
Okay, thank you.
So we have to finish the debate. Thank you once again.
Thank you.
Great presentation.
So next, I would like to welcome Mateusz Zakrzyewski from Poland and Alia Cetina from Slovenia. And their mentor, assistant Lauro Žibana. Please join us.
Dear ladies and gentlemen, it's a pleasure to start a debate. The title is Use of Nutritional Supplement in Professional Sport Worth the Risk. And I am pro. Contra is Alia Cetina. And our mentor is Lauro Žibana. Thank you for helping our presentation. When we wanted to choose the topic, this one seems to be very easy, but after we started read the articles and study, There were more questions, their answers, and now we just want to share with our considerations. So the first, what are the nutritional supplements? The definition includes vitamins, minerals, herbs, meal supplements, sports nutritional products, natural food supplements, and other related products used to boost the nutritional content of diet. How many of you used one of these ever? So as we can see, most of the audience. So we just focus about sport nutrition products, which are most important in professional sports. These are high protein products, amino acids and BCAA, vitamins, minerals, herbs, carbohydrates, fat burners like L-carnitine, or bodybuilding supplements such as creatine. The table shows supplement use. This is the pointer. The supplement use in sports, professional sports, and we can see that it's 55%, so it's quite a lot. What can we gain during consumption of supplements? Is it worth? The newest studies shows that even though there is a well-balanced diet, is it not enough to maintain body homeostasis? So that means during professional exercise we need more supplements, and then we eat and drink normally. So what is the professional sports? What are these people? Actually, these athletes receive payment for their performance. So the professional sports for them is a job. They have to work very hard every day to achieve some kind of goal. And the dream for this kind of athletes is to win the Olympic Games, which has to be covered by an effort. So what kind of effort? The long-lasting training, daily work 2-3 times per day, sport camps, and plenty of burned calories, stress during competition. Okay, now the second question for you, I will show you two pictures, and you will answer which one would you think that there is an athlete figure. The first one on the second one. Who is for the first one? Who is for the second one? So we are good. The second one is one of the most famous discus thrower nowadays. So as we can see, sometimes the shape and the figure of muscles, it's not important. It's only a benefit in professional sports. So there are more important values like strength or stretch or flexibility and so on. According to American College of Sports Medicine, what is required to manage this effort? So strategies for weight change. Usually if there is an endurance training, athletes put a lot of effort in this, like for example running, and they burn a lot of calories, which has to be supplemented by food intake or fluid intake. So there are high energy needs and special nutrient needs during training, and the other special during competition where the stress can occur.
As Mateusz said, professional sportsmen has a lot of nutrient requirements, but they can all be met by a good diet. If they explore their chances, if they know their needs, and if they know what they need, they have a good chance to do a proper diet and with that achieve the goal. Unless there is a clinical condition in which he does require nutritional supplements.
Yes, Alia, you are right, but if there is a very hard training, muscle cells require something more. That's why the creatine is so popular. We can find in in small amounts in animal foods. That's a nitrogen-containing substance, and its supplements improves performance in both strength and endurance athletes. Let's say just a few words, how does it work? The creatine in a muscle cell binds phosphate, which leads to phosphocreatine production. And during the phosphorylation, the ADP takes this phosphate from phosphocreatine and it produces ATP. So where is more creatine, there is more ATP and more energy for the muscle cells. So what are the benefits? You can do more repetitions during training and you can increase total body and lean body mass. It's also widely used for resistance training, lifting, or fast repetition exercises.
Well, let's say I do agree with you about the L-carnitine beneficials, but there are also some bad sides. This research on the slide said about big rates of mortality and morbidity with the mice used L-carnitine supplements. And it is not a lonely rider. There is a lot of cases of bad influence of nutritional supplements on organism. For example, this one, Oxyelite Pro, was used a lot in Hawaii and in other American states as nutrition that can benefit, that can extend your lung performance. But in this case, it was really harmful. In almost 100 cases, it caused severe liver damage, resulting in acute liver failure. In 3 of them needed liver transplantation, and 1 of them even died. And as I said, there is a lot of cases of that. For example, hepatotoxicity is the biggest problem, but there is also problems with other organs. For example, ephedra, comfrey, kava, the oral substances launched on the market because they had good beneficial effects as a nutritional supplement, but as it turned out, they were cancerogenic or they even had really severe effects. Ephedra caused a lot, almost 100 deaths. So at the end, we need to consider all the liver damage, heart attacks, strokes, deaths, and other adverse effects that can come with use of nutritional supplements. And keep in mind, all of those effects are not seen right away. You need time so they can be seen. And that's why the sportsman doesn't consider them before it's too late.
Yes, you are right. Some of them are very harmful, but what would you say about amino acids, BCAA, and proteins? Let's start with beta-alanine. It's the most important factor for decreasing pH in muscle cells, which is higher due to lactic acid formation, actually, during exertion. And the newest researchers has proven that 4-week supplementation of beta-alanine during professional training increased muscle work by 30% and 10-week supplementation by 16%. The second one, glutamine, is important for cells of the immune system, such as lymphocytes and macrophages, which may be decreased with prolonged intense exercise or overtraining, and may also promote muscle glycogen synthesis and has been studied for potential enhancement of muscular strength.
But all of them, the problem is that when you mention the immune system, a lot of sportsmen use multivitamins, multimineral substances just in case. And it's not that they are sometimes they have no effect at all, but sometimes they can be even harmful. Let's just mention a few. You see on the slide here, 94% of adults uses at least one dietary supplement, which is a lot. And if we combine this to professional sport, when they want to perform, they know they have bigger needs than the other population, and they overuse it a lot, we come even to the harmful effects. For example, vitamin A has in higher doses hepatotoxic and teratogenic effects, as well beta-carotene, which increases the risk of lung cancer. And the ones that are really widely used, like vitamin C, vitamin D, selenium, they have no statistical effect at all. So why take them?
Is it right? But what if the exertion during the athlete's performance is higher than food intake in a well-balanced diet? It can be substituted by carbohydrate solution, which is very important fuel substrate during prolonged exercises, and it maintains body glucose level and deliver energy to the muscles. So maintaining the normal function of the immune system, especially what I mentioned before, lymphocytes, macrophages, requires an adequate amount of glucose. So the key factor for maintenance of heavy training schedules and successful athletic performance is carbohydrate availability. And lack of glucose leads also to protein catabolism, so muscles are not formating anymore.
All the time we're listening about the good effects of nutrients, which can also be met by a good diet. But the nutritional supplements have a lot of adverse effects, and you need to know that the dietary supplements are not required to be tested for safety and efficiency before they are put to the market. And it's not like with pharmaceutical drugs. In other words, any product labeled as dietary supplement is assumed to be safe until the evidence emerges to prove contra. So what does that mean? This is a good article which was published in Forbes, which has all the arguments that are contra using nutritional supplements, and it actually says we are playing Russian roulette when choosing one, and I will explain now why. The problems that comes with the use of nutritional supplements are not only the loose regulation. It comes down to an economical interest on manufacturers. You need to know that in last decade, the use of nutritional supplements and the one launched on the market increased 20 times, and it's $32 billion market in US. There is 85,000 nutritional supplements launched on the market in America. And all this with loose regulation come with a lot of problems. As well, the one that I will mention now, contamination during the production. But contamination with what? Did you know that the research has shown that the high proportion, even 15 to 25% of the supplements that are on the market may contain prohibited substances for professional athletes. This is the point, maybe the most important for the professional athletes. What that means, they can use multivitamin supplement and they test positive on a doping test. And this is something that we should consider. This is the list of all the supplements containing those. So, for example, you see stimulants containing, stimulants can be found in almost all the nutritional supplements on the market. Some of them even contain traces of steroids and diuretics. And this is what they need to be careful about. And what are the actual consequences of a positive doping test for sportsmen? They can get prohibition of competitions for a period of 2 years. And after 1st January in 2015, they will get, for the first positive doping test, the prohibition of competition period for 4 years, which is, for most of them, actually the end of career. And if not, they will lose their reputation and their whole career will depend on that incident. What you also need to know is this is the number of the products that were actually put off the market because of that. And what you need to know is the strict liability rule, which means that even though they used nutritional supplements in order to perfect their dietary needs and stuff, they still tested positive, and there is no excuse that would change the result. What are the reasons for the contamination of those? Some of the companies deliberately added some prohibited substances, because then with this supplement you get greater and faster achievements. And if you see the results immediately, you will use more of this substance. But more of them is contaminated with ingredients that are in the actual product, which means the manufacturers want to decrease the resources they put into the production. And this is why they buy really cheap ingredients from countries that are not that reliable. The most of them comes from China, and they're actually contaminated with prohibited substances. And another thing is that they use the same machines, the same production chain as they use for steroids and other prohibited substances to produce these ones, to produce nutritional supplements. And what does that lead us? This is a graph that shows that even after 16 hours after taking a dietary supplement, you can still test positive on a doping test. So it's really high risk for the sportsman. Remember, 15 to 25% of all the dietary supplements has traces of this. At the end, I would like to ask you, how many of you will still consider taking nutritional supplements? Raise your hands, please. Of course, there is a few of you. You're not a professional sportsman, so the doping problems, it's not that concerning for you. But even though, the athletes should carry out a cost-benefit analysis at the end. Use them, not to use them, risk a doping, not risk the doping. All in all, they need to have a lot of data, they need to do a lot of research, they need to know their dietary needs to use the proper dietary supplement or not, or just meet the proper diet.
If you use them, you can look like this guy. Thank you for your attention.
Thank you very much for this excellent presentation. First, I would like to invite your mentor to have a few comments.
First of all, thank you for a very nice presentation to both of you. I would like to stress that today we are talking about professional athletes. So from pharmacological point of view, even those traces of contaminated substances, they might not be pharmacologically active, but they might lead to a positive doping test result. So what we are speaking is basically a system that is meant to test athletes to use forbidden substance 2 weeks or even 2 months ago. And on the other hand, we have an athlete who is taking a nutritional supplement 8 hours ago, and he tested positive because the concentration of a steroid or a stimulant is on the same level. So it's hard to distinguish what was the motivation to use. The second point I would like to stress out is that from the history, since 2000, we have some athletes who clearly showed that they use nutritional supplements and they were banned from competition. The most famous case is Kicker Wenzel. It was an American swimmer. He was a candidate to go to the Olympic Games in 2004. And one of his tests, he was tested for anabolic steroids. Of course, he said, okay, I didn't do it. So how did this substance enter my system? And what he did is he did a big investigation. He took all of his nutritional supplements to analytical laboratories. And they found in the multivitamins pills that they were actually contaminated with steroids. He went to the court and he won, I think, $500,000, but he never saw the Olympic Games. So basically what we are talking here is the importance, to consider the importance in the perspective of professional athletes. So maybe we can start our discussion from this point of view.
Thank you. Any questions from the audience?
I have a question. Since supplements that professional athletes use are not usually the supplements we can find in, I don't know, DM shop, they're like same supplements which show pretty much the same components have much different prices, and usually the ones with bigger prices are able to guarantee that there would be no contamination because they use more quality ingredients, or maybe they use separate manufacturing processes. So maybe in that case, by using proven manufacturers and buying the most expensive ones, professional athletes could be somehow shielded from this doping risk.
I shall start, you can jump in. Thank you for a very interesting perspective. Actually, nutritional supplements can be found also in a classic supermarket, because nutritional supplement is as far as from multivitamins to very specific nutritional needs. So also those multivitamins are contaminated, especially from, let's say, startup companies, because they need to make money very early. However, there is let's say, a middle way. If the athlete still insists to use certain nutritional supplements, maybe because of placebo, maybe because he believes that it will improve his performance because his nutritional needs are higher than he can take with the diet. There are some companies on the market in Netherlands and in Germany and in US who actually take randomly out of those 100,000 products. So we are talking about a huge number that is increasing every year. And they randomly test those products. Let's say 15 to 20% are contaminated. And they publish on their website every day the new nutritional supplements who have been shown to be contaminated. On the other hand, some in Netherlands, they publish nutritional supplements who have been shown to be clean, also with a lot number. So athletes can use this information. However, the best test that, let's say, the top elite athletes are doing, actually, at least in professional cycling, where I got this information, is they take the nutritional supplements to the lab. And the lab actually tests their own nutritional supplement before they are using it. This analysis is, let's say, this is a 100% safety in the end, but it costs €500 for one nutritional supplement. So not all athletes are financially, can, let's say, enable this protection.
If I may add, most of the athletes that are problematical in this case are young athletes which don't have the means and they don't know a lot of it, so this is the problem.
Is there any proof that just vitamins, nothing else, have any benefit at all to sportsmen?
Yes, if he has a lack of vitamins. So if, let's say, he's in homeostasis and he is... it's a need. You know, sometimes during the intensive training, he can have a hypovitaminemia, let's say. His vitamin B or vitamin C levels can be decreased if he's not using a proper diet. In this case, nutritional supplementation with vitamins is, let's say, clinically indicated. If he's healthy and his vitamins levels are okay, which probably is for majority, then extra supplementation, as Alia showed, can actually have side effects. So it's not indicated.
Okay, but I just mean professional athletes who go to Olympics, they have nutritionists and dietitians who arrange their diets. So who would give them vitamins when they can get them through food? If they're healthy, I mean, of course.
Usually those athletes who have money to afford nutritionals, they don't use nutritional supplements. This I can also tell for my practice because I work on many of doping controls. And when we ask them what supplements, what medications they use, usually the really elite athletes who are supported by nutritional advices, they have a blank place. While on the other hand, we had also cases where athletes stated 20 nutritional supplements. So we had to write additional form. And I even evaluated, and they use really not smart, because some of the nutritional supplements are doubled. This means vitamin E is in 3 of their nutritional supplements. So in the end, they have 600% of recommended daily intake. And this can lead not to beneficial, it can actually lead to toxicity. So here some of them are not using wisely the nutritional supplements.
So it means that the knowledge of nutritional supplements is the most important, because if somebody can manage and arrange what kind of vitamins and what kind of supplementation he needs, it could be proper.
Hi, I was just wondering, would often or constant usage of protein supplements damage the kidneys eventually?
In the dosage prescribed, there is no scientific proof, but it has been a very strong debate on this, but so far there has not been any scientific papers on stating this. But however, we are speaking about the recommended intake.
What about the protein supplements and liver damage? I remember a case of a Slovenian footballer that got hepatitis. I think it was...
No, we have to know that sometimes athletes, even if they use steroids, they say, okay, I was just using a nutritional supplement. However, as Alia showed, there has been a lot of cases in last year, let's say about 50 to 60 athletes with really severe liver damage. But it has been shown that this is due to the contamination. There has been a certain substance in some nutritional supplements that was inducing this hepatotoxicity. Protein per se, basically, this we are talking about meat. It's a nutritional ingredient. It shouldn't induce liver injury. However, when you will be as a clinician in a practice, it's very hard for an athlete to come to you and say, okay, I'm using this and this doping. Because if this information is leaked out, basically his career can come to an end. So you have to take really good care. With a good selection of clinical tests, you can actually see if he's using testosterone or anabolic steroids. So you can actually check from his blood if he was using doping, or maybe he just had a nutritional supplement that was contaminated. And since we are starting this topic, thank you for the question, I think as a clinician you also have responsibility to report all the nutritional supplements that could induce hepatotoxicity, because there are plenty. We see that in American market there are 200 to 300 products per year taken out because of toxicity effects. So if we are not reporting them to our regulatory agency, they just keep remain on the market and keep damaging people. So keep this in your mind.
Thank you.
Hi, I guess we've all probably heard that taking steroids affects your performance in bed. And I'm asking if there's any truth to that.
You mean if an athlete who is on anabolic steroids has a higher performance? Actually, it has been shown that vice versa. The initial phase of taking testosterone, you have a higher libido. However, you have a testicular atrophy because your endogenous production of testosterone goes down. You have also inhibition of production of spermal cells, and after chronic usage, your libido goes down. And you get very emotional. And why this happens? This is because if you have a higher intake of testosterone, aromatase converts those levels of testosterone to estrogen. So basically, athletes who use higher level of testosterone have at least 100 times higher concentration of estradiol in their blood than the normal healthy woman. And this is also why, for example, you can see in the US cinema, sometimes you see a very big, strong guy, muscular, and when they go out of the cinema, he's crying and the girlfriend is wiping his tears because his personality is actually changed due to a high level of estrogen. So his performance is not increased, if that was your question.
Thank you. We have time for some more questions, if there are any.
Hi, just one more question. That was very interesting, you know, the research of higher incidence of carcinomas in relation to some diet supplements. But I'm wondering if it was proven in not only on mice in laboratories, but also on senior maybe sportsmen who have used those supplements for a long time. Have they actually, you know, been carcinogenic in humans over a long usage? Thank you.
The research on professional athletes is very tricky. It's hard to prove, especially because of the history. let's say until recent majority of the athletes was usually taking some sort of doping because of the very weak analytical methods. So it's hard to speculate on this basis. However, the interesting finding was for the Tour de France cyclists actually shown that they have a less mortality in the normal population. So probably still their activity outperforms the toxicity of the doping. However, the study that Alia showed, maybe you can go back to this slide, actually is on beta-carotene, and it was on a general population. So what they showed is that there is some increase in lung cancer if you have normal vitamin level. So in this way, what I would say is the vitamin supplementation is needed only if you have a decrease. If you are already on a normal level and you supplement to a higher level, of course the body must metabolize, and especially with these lipophilic vitamins, A, D, E, and K, it can be a problem. So we will hear a lot about this in the future, but so far a lot of epidemiological evidence show that taking just for this anti-age philosophy vitamins, if there is no serious need, is actually having the vice versa effect than the motivation. And this has been proven in literature with many support. So.
And the problem is that even doctors prescribe it just in case, a lot of doctors. So maybe it's a title not as much for professional athletes, but for general population to consider.
Hi, I would have a question for a mentor, and it is connected with vitamin D, because we heard on the lectures from pediatrics that they actually recommend taking vitamin D your whole life. They start with children and continue. The new guidelines are to take them your whole life. So I would like to ask you, what is your opinion? It doesn't really have a lot to do with a sportsman, but anyway.
Yeah, vitamin D is it's a very good and very intriguing question, because this is one of the only vitamins that has a strong scientific support that actually taken in some, let's say, risky population, in those who are not daily exposed to the sun, basically with the modern lifestyle, there is a clear indication that it has health benefits. However, I would not like to opinion myself, but I have to stick to the scientific literature. So slight supplementation of vitamin D in certain subpopulation has been proven to be beneficial. So this is the finding. However, with the athletes, majority of those athletes who are exposed to the sun, let's say cyclists, they are 5 to 6 hours on the sun every day. They have more than enough vitamin D usually. Vitamin D supplementation is usually for those who are indoor athletes, who basically do all their training closed and they are not exposed to the sun, let's say gymnastics or basketball. There has been some recommendation to use. However, I would recommend checking the blood levels and deciding on this basis, if you have the money to, of course, do this regular screening.
Okay, thank you very much. We will have a break and then start with a new session.
I would kindly invite the pro student, Matej Goričar from the University of Ljubljana, to join us, and Contra, Tomislav from the University of Zagreb. And also, if their mentor, Dr. Borut, could join us here, it would be really nice. So the podium is yours.
Thank you. So good afternoon, fellow colleagues, chairman. Congratulations to the organizing committee for creating this event. My name is Matej Goričar and I'm a medical student from Ljubljana. This is Tomislav Bubalo, my colleague from Zagreb. We plan to speak about whether stem cell therapy is effective in heart failure patients. So first, we will give you a short overview of the pathophysiology of heart failure, and then present you some pro and contra arguments. You will see that it is currently not possible to give a definitive answer, so we hope you will enjoy the debate.
So let's start with the definition. What is heart failure? Heart failure occurs when the cardiac output doesn't meet the needs of the body. Basically, etiology, it can be divided into the two, ischemic or non-ischemic. A symptom is caused by the low blood output, and it's shortness of breath, weakness, fatigue, and swallowing of the legs. On this picture, you can see normal heart, systolic heart with a systolic dysfunction, and heart with diastolic dysfunction. In systolic dysfunction, the main problem is low ejection fraction. It is less than 35%, and in a normal heart, it's over 60%. Because of why is ejection fraction important in this topic? Because the main goal of the stem cell therapy is to rise ejection fraction. So basically, the beginning of the stem cell was focused on the systolic dysfunction. And in diastolic dysfunction, the problem is not in the ejection fraction, the problem is in filling the ventricles. So there is not enough blood in it, and because of that, there is heart failure.
So on this slide, you can see the vicious circle of progression of heart failure. Injury to the cardiomyocytes causes a decrease in the pumping ability of the heart, and therefore insufficient cardiac output. Compensational mechanisms are only able to maintain cardiac output for some time, but they eventually lead to pathological changes such as ventricular remodeling and clinically expressed heart failure, which then even further reduces the pumping ability of the heart. Precise mechanisms of transition to advanced chronic heart failure are not known, but it is clinically defined with symptoms that are no longer manageable with medication, hemodynamic criteria that include ejection fraction lower than 35%, and peak oxygen consumption lower than 40 milliliters per minute, and some functional criteria like 6-minute walk test less than 300 meters. So increased survivorship after acute myocardial infarction, improved treatment of hypertension and other cardiovascular diseases, and aging of the population have led to a significant increase in the prevalence and incidence of heart failure. It is present in 2 to 5% of general population and in about 10% of people older than 65 years. It carries a 50% mortality rate, 5-year mortality rate for severe heart failure, and is responsible for more than 1/3 of cardiovascular deaths in the United States.
There are two classifications of heart failure. One is American College of Cardiology, and the second one is New York Heart Association. We use both of them. The difference between ACC and NIHA is that ACC is based on structural disease, and NIHA is a functional classification. It means that it's based on symptoms. If you have ACC-A stage, it's not the same as class 1 in NIHA. So don't think that it's the same, because it's important in the second slide in treatment, because the stage A, it means that there is no structural disease, but there is some high risk. So the treatment for stage A is just to lower the risk factor. And if you start rising in the stages, stage B and stage C is the medical treatment. For us, the stage D is important because this is the stage with the best medical treatment. The condition is not good enough. In this condition, stage D, doctors need to start thinking about new way of treating the heart disease, such as a left ventricular assist device or even the heart transplantation. Now we have stem cells, and in the stage D, this is the place where stem cells need to be put in it. So maybe we want to know in this debate, is the stem cells alternative for heart transplantation or left ventricular assist device?
So you probably know that stem cells have remarkable potential to develop into many different types of cells. In addition, in many tissues, they serve as a sort of internal repair mechanisms, dividing essentially without limit to replenish other cells. They are distinguished from normal cell types by three important characteristics. They are self-renewing, they are clonogenic, which means that they form identical clones, and they are potent, meaning that they can differentiate into different cell types. Potency ranges from totipotent, meaning that it can differentiate into any cell type, and unipotent, meaning that they can only differentiate into one cell type.
So basically we think that we know that cardiomyocytes are not able to replace, not able to regenerate, but recently we found out that approximately 1% of cardiomyocytes are replaced each year. Based on this information, Orlik in 2001 started a trial based on mouse model, and they proved that bone marrow derived stem cells could regenerate heart of the mouse if they suffer from the myocardial infarction. This sounds really good, but the problem is that they couldn't prove this same on the human body, on a human heart.
So what are the possible mechanisms of recovery after using stem cell treatment? Generation of heart muscle cells is one of them. Stimulation of growth of new blood vessels, secretion of growth factors, or some other yet unknown mechanisms. As Tomislav said, the beneficial effects on myocardial remodeling today were initially attributed to de novo myocardiogenesis, but this was not confirmed. So today, it is believed that they work through neovascularization and paracrine effects, reducing pro-inflammatory and increasing anti-inflammatory cytokines. So stem cell therapies are currently in the stage of assessment, and they are only carried out in facilities that do research. Basically, the method includes collecting stem cells from patient's own blood or bone marrow and injecting them into the site of injury. Different cells can be collected, and different approaches can be used for their application.
But there is still some field that is confusing and it's hard to interpret, such as what is the mechanism of acting, what is the ideal cell type and cell dose, routine and timing of delivery, and when is the clinical indication to use stem cell, and what is the clinical efficiency of that treatment. Basically, we want to know, when we are looking at the stem cell therapy, if there are any improvement in symptoms in the left ventricular function and left ventricular geometry. In 2002, there was first clinical trial that evaluating the effect of stem cells. And in 2006, 3 large randomized clinical trials were published, and they didn't show any benefits from stem cell therapy in ischemic heart failure. But there is still some possible adverse events of stem cells, such as tumorigenesis, immune reaction, dysarrhythmia, atherogenesis, neointimal hyperplasia, and adverse effect of granulocyte colony growing factors that are used for stem cells, that are used for moving stem cells from bone marrow.
But luckily, the researchers didn't stop there, and further clinical trials were made. And they suggest beneficial effects of stem cell on the function and remodeling of ischemic myocardium. You can see in this picture some of the trials we were talking about. And yes, some show no effect, but others show some increase in ejection fraction. Furthermore, this is the latest review from the Cochrane collaboration, which is renowned for their systematic reviews and meta-analysis based on well-conducted controlled trials. It shows that while no clear benefits of this therapy were observed in the first year, after long-term data was analyzed, mortality rate was lower, hospital readmissions were reduced, and adverse effects were rare. If we move on to non-ischemic heart failure, these patients represent a good target population for such therapy because their bone marrow stem cell functional capacity has shown to be significantly less impaired, and they also have a higher number of circulating progenitor cells compared to patients with ischemic heart disease. Unfortunately, very few trials were conducted to date, but they have shown a significant improvement on ejection fraction, regional hypokinesia, and decrease in N-terminal of the prohormone brain natriuretic peptide, which is a marker for establishing the prognosis of heart failure. Second trial showed improvement in ejection fraction and quality of life. And third trial showed increase in ejection fraction, 6-minute walking distance, decrease in NT-proBNP, and also lower total mortality.
Matos showed us some really interesting article, but British Medical Journal published one article named Discrepancies in Autologous Bone Marrow Stem Cell Trials. They found out that over 600 discrepancy in 133 reports from 49 trials. They found out that there is some discrepancy between measurement and increasing of ejection fraction. That means there is probably some measurement bias in those research.
Okay, I cannot disagree with that. But we can somehow deduct that first-generation clinical trials have shown that cell therapy is definitely safe and it is modestly effective.
But we found out that stem cells do not transdifferent into cardiomyocyte or new blood vessel, what we expected, and that there is low tissue retention of cell after delivering them into the heart.
So in conclusion, we know that there are very limited therapeutic options for advanced heart failure at present because there is a lack of donors for heart transplant, which would be the best therapy, and because there is a short-term viability of left ventricular assist devices. And fortunately, some studies are showing improvements in parameters of cardiac function after such therapy.
But there is still a problem because we don't know the mechanism of such therapy, the mechanism of stem cell work, how the stem cell working, and there is still lack of proven clinical efficiency of that still now.
So, although a significant step forward was made in stem cell therapy, we can both agree that several important questions remain unanswered and therefore represent a focus point for new research. If eventually found to be effective, stem cells might offer an alternative or complementary treatment to standard drug and surgical treatments for some patients with chronic heart disease. Thank you.
Thank you.
Thank you for the presentation. I would like to give the word to their mentor, Dr. Juk, if you have any comments or questions.
Oh, thank you. I think they pretty much said everything already because we have a novel technology at its earliest stage in terms of research and also clinical effectiveness, which will be probably or not be in clinical practice in like 20 years. However, on the other hand, we have a population, advanced heart failure. I'm not sure if you sense, but advanced heart failure has a worse prognosis than pancreatic cancer. So this is a population that it's worth investing even with a method that might not be as effective and maybe as financial intensive as to prove effects in 20 years from now. That's pretty much it.
Okay, thank you. Do you guys in the public have any questions for either one involved?
We have a question here.
You told us that there are just a few centers in the world that are involved in this research for now. As I know, Ljubljana is one of these centers. So maybe Dr. Juk could tell us what are your personal experiences with patients that went through this procedure?
The group is led by Dr. Vrtovec. One of the trials was also mentioned in the presentation. The focus of the group is on patients with advanced heart failure. It has shifted from ischemic heart failure. We previously thought that ischemic heart failure being marked by fibrosis might benefit a lot from stem cells, which did not prove right. However, in non-ischemic heart failure, which is also very a type of microvascular disease, stem cells have improved both ejection fraction, exercise performance, anti-proBNP as a marker of advancement of heart failure, and very, very few side effects. At the beginning, the problem was that the number of stem cells was very, very low, so we tripled it. It was tripled from some millions to some billions of cells. And it's been proven that such number of cells is better nested within the myocardium, which in turn results in better improvements of ejection fraction. But again, this is a method currently used in research purposes for groups of patients that are very ill, and might not have any alternative at present in order to improve their well-being. So there is no mortality data, there is no morbidity data.
Thank you. Anyone else?
Isn't it true that that the stem cells don't know how to stop? So when you inject them, they continue multiplying, and eventually they will become tumorous.
Well, tumorigenesis is one of the concerns of this therapy. However, when they applied stem cells with a radioactive marked stem cells within the myocardium, the nesting of the cells, resulting nesting of the cells was less than 5%. And there was no signs or symptoms that, the appearance of tumors might be clinically significant. And yes, you're right, theoretically it's possible, but then you have to bear in mind that if you transplant a patient, he will get immunosuppressive therapy, and there we have evidence that the rate of tumors increases as well. So this balancing on and off is, I think, in favor of stem cell research still.
I think Dora has another question.
I was wondering about method of application of those stem cells. If I understood correctly, they were just given intravenously, or?
No, the actual method is that you give granulocyte stimulating factor, then you collect cells, and then you have to implant them in the myocardium either transepicardially, so through the skin, which is a very, very invasive method, and this is supposed to be a non-invasive mode of treatment. Then you could puncture the myocardium via a coronary angiogram. You puncture the myocardium, and then the most widely used is intracoronary. So you go with the catheter in the coronary artery of the segment of the heart you think would benefit the most from stem cell application, and then you inject stem cells in the coronary artery, and they flow to the myocardium that this coronary artery is actually irrigating. So it's still an invasive procedure. It's an invasive procedure. You cannot just apply them intravenously because you wouldn't know where they would end eventually. And the main problem is currently the nesting of the cells. It was barely demonstrated that cells stay in the myocardium because for some time it was thought that they just release hormones and other paracrine factors that might promote the improvement of ejection fraction. But still, this is the mode.
I have also a question regarding something I think everyone saw on Facebook and in TV shows, the development of decellularized heart, which is then flushed with stem cells, so it's like a new beating heart with cells of the donor, which would not be rejected. Do you know maybe if there are some advances in that field which would be applicable to humans?
This is one way of research right now. This is one way of research, but there are several more. So I cannot answer you honestly which one is going to I mean, it's a very intensive field of research. They are trying to put human hybrid hearts into pigs to grow. They're trying total artificial heart, which is a completely mechanical heart. They are trying to improve left ventricular assist device, which is like an artificial heart, but taking just part of the load of the myocardium, and this is another option. I'm not familiar with the concrete research. I know the Facebook anecdote. I'm not sure where this is going, but we have to go somewhere because the current state, like the heart transplant, is a viable option, but there is not enough donors for the demands. It's just that. So I'm not sure where it's going to go.
Any more questions?
Yeah, of course.
One question for the two of them. If your father had advanced heart failure and he had limited options for transplant because of his blood type, because immunoserologic patterns or whatever, would you advise him to get stem cells or not?
So this is a difficult question because it's a bit personal. But considering that there is no adverse effects that really happened, of course they're possible, but this kind of therapy is safe, so I think it is a valuable option.
Well, for me, its answer is no, because there is still some mechanical support, like left ventricular assist device, that can be the bridge to transplantation, and after some time the heart will appear, because it's Eurotransplant and Europe is a big country, so it's after some time probably the heart will come.
Yes. Both are right. There is a lot of options. LVAD is one of them, but LVAD will give you 2 extra years. It's not true, actually, that everybody will get a heart, because if you have an immunoserologic type that is not compatible with most hearts, you might die because of it. So I think stem cells are a viable option. The question right now is not if we would put them into our relatives, it's how much they cost and if it's worth the financial input. And that's not an answer for the I mean, we need to focus on effectiveness, not on finances. So that's my thought on that. I would advise it. Yes, I would advise it.
Thank you.
I would also like to thank the presenters and their mentor. And we're going on with the next discussion, which has the title, Unconscious Patients After Cardiac Arrest Have to be Treated with Hypothermia. The pro aspect of the topic will be presented by Matica Ausec, which is a medical student from Ljubljana, and the contra aspect will be presented by Stella Velak. I also invite their mentor, Dr. Peter Rachel, to join us on stage.
Okay. Thank you very much. First of all, I would like to thank the organizers for having me here. It's a great honor to be here again this year. Me and my colleague are about to present you the topic whether unconscious patients after cardiac arrest should be treated with hypothermia. This was done under the mentorship of Dr. Peter Rachel. My name is Matic, I'll be presenting the pro side, and this is my colleague Stella, she'll be presenting the contra side.
Hello.
Okay, so hypothermia after cardiac arrest, it's a big thing. Nowadays in medicine, we know a lot about medicine. We have a lot of evidence. We know what treatments are the best. And so it's really hard to get to a breakthrough. It's hard to get to a revolution in medicine. I'll give you an example. Aspirin in the primary prevention of myocardial infarction. A lot of large studies and even meta-analysis show that aspirin does not prevent any myocardial infarction as in primary prevention in women. Did you know that? And we still treat it as a cornerstone of prevention. So yes, new technologies, new treatments offer a benefit of 1%, 2%, maybe a few percent. But in 2002, we got to a revolution. We found out that hypothermia after cardiac arrest improves outcome for about 15%. It improves mortality, it improves neurological outcome. So it was huge. It was as huge as percutaneous coronary intervention. It was so huge that it was immediately implemented in resuscitation guidelines in 2005 and then again in 2010. So, but let's first start with what this hypothermia is and how we do it in Ljubljana. So please, Stella.
Okay, so basically what I do at University Medical Center here in Ljubljana, they start with a cooling procedure already in out-of-hospital setting. This basically means as soon as possible after cardiac arrest. And there have been also cases where the patients were delivered to the ICU, you know, just with frozen vegetables or meat applied to their body. So basically they use anything just to lower the body temperature. And then they proceed with the cooling at the ICU with the use of ice packs, just simply applied to the torso, around the neck or limbs, like you can see on this picture here. And they also use intravenous cold fluids. And they try to reach the target temperature in the range between 32 to 34 degrees Celsius, and then maintaining for the next 24 hours after cardiac arrest. And then after this cooling period, the rewarming starts. So just a little bit more theory of what hypothermia actually is. It is defined as body core temperature below 35 degrees Celsius. And then it's further subcategorized into 4 different groups. And actually in those patients after cardiac arrest, mild hypothermia is used. This means the temperature range between 32 and 35 degrees Celsius.
Okay, so let's start our story with 2002. What actually happened there? Two a bit large trials came out. One was, the first one I'm about to present is the European trial. It was a multi-center randomized control trial. It included about 280 patients. They treated some patients with hypothermia if they were unconscious after cardiac arrest, and some patients were treated normally in normothermia.
Not really, but okay.
Okay, so what this study showed is that hypothermia group had a 14% better lower mortality, and it had 16% better neurological outcome. So it was really big compared to normothermia. And one really important thing is that this study showed absolutely no statistically significant side effects of the hypothermia. No side effects. The next study, also in 2002, is from Australia. It's also multi-center, pseudo-randomized control trial, hypothermia, normothermia. Patients with ventricular fibrillation as an initial rhythm were involved in the study. It had a smaller number. It had around 80 patients. And this study showed even greater improvements in neurological outcome and in mortality.
No,
and
not
again,
in mortality.
And again, it showed no significant side effects of the hypothermia. Several other studies followed, and then in 2010, a Cochrane review was made, a Cochrane review that was mentioned also in the previous presentation. So yeah, this Cochrane review showed confirmed all the previous trials. It showed that it actually does improve neurologic outcome, it does improve mortality, and it showed no significant differences regarding the side effects. So I would like to present two other studies that are not important regarding mortality and neurological outcome, but just this study showed it involved patients that presented with cardiogenic shock after resuscitation, and they were treated with hypothermia, and this study showed that hypothermia is safe even in patients that are hemodynamically unstable. And the next study was a feasibility study about some helmet device for cooling. That's not important. What's important about this study is that it involved patients that had a systole or pulses electrical activity as the initial rhythms, and it showed that hypothermia is completely safe even for these patients, though the numbers were too small to assess mortality or any kind of outcomes. But again, no side effects. I would like to stress again, none of these studies showed any side effects of hypothermia. Oh, sorry.
Okay, yeah. So I agree with you. Like back then in 2002, this hypothermia was really quite a sensation, but so far they really didn't have any treatment. It seemed to have an effect with those patients after cardiac arrest. Before, they're really doomed to either death or dismal neurological function. However, even back then in 2002, there were really some great minds that actually questioned this.
One great mind.
No, there were quite of them. So they actually questioned this magical therapeutic value of hypothermia. They were basically saying that the supporting evidence, even with all those trials, is still limited. And those trials had really a lot of flaws in conduction, and that's why they shouldn't be taken very seriously. In addition, their samples were really, really small, like 77 patients, oh my God. And then selective samples with very strict inclusion criteria. And they were also studying patients just with ventricular fibrillation and also ventricular tachycardia. However, current guidelines recommend the use of hypothermia also in patients with other rhythms, meaning not just ventricular fibrillation, but also other shockable and non-shockable rhythms. And almost a decade later, the question still remains, should therapeutic hypothermia be extended to the patients outside the originally described populations? Many claim that no. And also a lot of people are saying that those studies are really biased, that the matching between the groups was really poor. In fact, one of those, the biggest trial, actually stopped because of the lack of funding. They ran out of money.
It was not because of lack of funding, but because of the date limit of the funding.
Okay, yeah, and inclusion rate of those was like 8%. They screened for 3,500 patients and included only like, I don't know, 200. This is like really a low number. And also, all those studies basically failed to answer maybe the most crucial question, what is the ideal and the most beneficial target temperature? And also, they didn't address the initiation and duration of hypothermia nor the rewarming rate. And also, we need to bear in mind that regardless what Matit said, hypothermia is associated with risk of side effects. We need to know that cooling the body to the temperature 32 to 34 degrees Celsius and also rewarming as well, is associated with risk of developing side effects.
Theoretical risks in the books.
Okay, still, but there is a risk. And I mean, cooling the body to 32 degrees Celsius represents a stress for entire body, for all the organ systems. And those side effects are numerous and maybe not as innocent as they sound, like metabolite disturbances that can eventually lead to, I don't know, arrhythmias, ventricular fibrillation, insulin resistance, diuresis, pneumonia, sepsis, coagulation disorders. We need to be aware of those side effects. And also, like before you said, you know, normothermia versus hypothermia. Well, this normothermia label is actually wrong because what happened in those trials is that those normothermic patients actually developed fever because they didn't actively control the temperature in those cases. So a lot of people went to the hyperthermia range. And it is a well-known fact that hyperthermia is associated with risk of side effects, the poor outcomes, and increased mortality in those patients. And so what happened? On November 17, 2013, Dr. Meeuwsen and the colleagues published an article in the New England Journal of Medicine called The Targeted Temperature Management at 33 versus 36 degrees Celsius after cardiac arrest. And basically, what they were trying to find out was whether the good outcome in those patients was due to hypothermia or due to prevention of fever, which is associated with poor outcome. And so they will just basically comparing two target temperatures, 33 and 36, both intended to prevent fever. Okay, I really have to stress this. This trial was huge. It was a very superbly executed trial, which was international, multi-center, randomized clinical trial. And they included 36 ICUs in this trial, and nearly, yeah, and in Europe and in Australia. And this trial had nearly 1,000 patients included, which makes it the largest trial of its kind. And just for illustration, this sample was more than twice the size as both those 2002 studies combined. So it is really huge. And also, they included broader populations in this trial with fewer inclusion criteria, and also not just patients with ventricular fibrillation. So, of course, this makes this sample more representative and applicable to everyday life situation. Okay, just a quick overview of design of the trial. So, actually, when they stopped cooling the patients, they were still maintaining the body temperature below 37,5 degrees Celsius until next 72 hours, which means that they were actively preventing fever for additional 3 days after cardiac arrest. Whereas in previous trials, as I already said, a lot of patients developed fever, and which, of course, confounded the results. And also, one very brilliant thing of this trial was that it included a protocol for withdrawal of life-sustaining therapy. So when they were basically deciding whether or not to keep the patient alive, this patient had to meet already specified criteria in order to be taken off the life support. Whereas in previous trials, they were, just deciding on a daily basis, like, okay, he looks bad, his prognosis isn't really cool, and so they just unplugged him. But with the use of such protocol, they eliminated one very huge variable. And okay, if we take a closer look to the outcomes, we can actually see that cooling the patients to 33 degrees Celsius group did not show any benefit compared to the 36 degrees Celsius group regarding death or neurologic outcome. You can see that percentages are basically very similar. And also here on this curve, you can see the probability of survival for those patients. And you can, again, see no big differences among the groups.
No difference, yeah.
Yeah. So what this trial showed was that hypothermia did not prove to be any better at just this near normothermic treatment of the patients after cardiac arrest. And then this raises a question: is therapeutic hypothermia actually therapeutic? What this trial showed was that it's really the active prevention of fever that really matters, and suggests that the real value of targeted temperature management is not the induction of hypothermia, but rather prevention of hyperthermia, because, as I already said, fever is associated with poor outcome.
Okay, thank you very much. First of all, I would like to comment on one thing. You said that patients in my studies weren't in normothermia, that they were hyperthermic. Well, that's not actually true. They weren't actively cooled, but they were trying to keep them in normothermia with antipyretics, and a small percentage of them actually developed fever.
No, it was not a very small percentage.
It was a small percentage.
It was not a very small percentage.
Continue with your study. That your study is not actually a case against cooling. I would like to stress this. It's not against cooling. They were,
I agree.
Even in this study, they were actively cooling even the patients in 36 degrees group.
I agree. It was still targeted temperature management. Okay.
Yeah, the patients after cardiac arrest go into severe systemic inflammatory response syndrome. And they tend to go into hyperthermia. So in order to keep them at 36 degrees, they had to actively cool some of them. And they actually did with ice packs and ice fluids and everything, just the same as the group of 33 degrees Celsius. So the treatment was kind of the same, just different targeted temperature.
Yeah, I agree with Matis. It was not like they abandoned this, cooling procedure. No, not at all. They just didn't cool as low to be classified as hypothermia, because hypothermia is below 35 degrees Celsius.
Okay.
But yeah, I agree with Matis.
So we have two groups of patients, both being actively cooled, one to 36 degrees, one to 33 degrees. So what are the differences between these groups? Are there any differences? No, there are no differences in regarding mortality, in regarding neurological outcome, in regards of significant side effects. No differences. So
okay, can I stop you right here?
No. Let me just make my point. So if we have two groups that are the same regarding the treatment, we would like to choose the one that it's easier to maintain, safer, and stuff like that. One would intuitively think that the 36 degrees group is easier to maintain and safer, but that's not true. The physicians that were treating for these patients, and even physicians in our clinical center of Ljubljana, can tell you that patients after cardiac arrest are much harder to maintain at 36 degrees Celsius than at 33, because at 36 degrees, they want to go into hyperthermia, and you have to actively cool them, but they want to go into hyperthermia, and they start shivering. So you have to put in more sedatives, more muscle relaxants, and you have to cool them actively, which means all these interventions prolong the time, the stay in the ICU, they prolong the time on the ventilator, they add to the cost, they add to the side effects. Whereas the group at the 33 degrees Celsius, they cool them down below their threshold, so they usually stop shivering, and they're much easier to maintain for the period of 24 hours, and then they can go back to normothermia. Okay.
Okay, can I? Okay, thank you very much. Okay, so before, like when you say what should be changed, you know, this procedure, I agree, yeah, it has been very well accepted over the past decade, but still, I think that the medicine needs to evolve. That's the essence of the medicine. And I think that every once in a while, we should really question our methods and reevaluate our current guidelines in order to achieve some progression in medicine, which is, of course, vital. And of course, before you said, okay, shivering, well, okay, this is really a technicality. Maybe I'll give you this one, but no one's ever died of shivering. However,
no, they die because of muscle relaxants, because of sedatives, because of the prolonged stay at
okay,
ICU.
well, in my study, they actually showed that basically the patients were taken off the ventilator not sooner when they were treated by hypothermia.
Okay, yeah, but it adds to all the interventions necessary.
Okay, still, and he was talking like there's no significant side effects. Okay, maybe I agree that mild hyperthermia doesn't really produce such severe side effects as it does, I don't know, moderate or severe hyperthermia. But still, there's been numerous of other cases, animal studies, human being studies that actually showed that cooling the body is associated with risk of side effects.
But no human studies.
Oh, I can show you the list of human studies. And before, like, isn't already one of the main reasons why they actually abandoned, you know, those cooling procedures in 1950 and 60s, because they were actually, yeah, because the patients developed such severe side effects, which were, of course, not, you know, compatible with the life.
Well,
so,
maybe 1950s, yeah.
Yeah, okay. So we can probably go on and on about the side effects for hours. So if anyone's interested, you can join us for lunch. But I think that in the meantime, we should really move on because the people are getting starving here. So yeah. So as Matit said, maybe one trial really is not enough, you know, just to refute all the other approaches and basically a treatment that has been well accepted. However, a lot of people are saying that this trial should be taken very, very seriously. I'm talking about this 2013 trial because it included a very large sample and it was a methodological masterpiece with broader and heterogeneous population. Of course, sample that is much more representative and applicable. And also compliance with the protocol was very high. And also, in addition, they adopted this protocol for withdrawal of life-sustaining therapy, which of course eliminated one huge variable. So yeah, I agree that maybe one study really is not enough, although with very high credibility. But I think that this study serves as a really good starting point, you know, just for the future trials to be done.
Okay, so are we out-fashioned with hypothermia? I don't think so. We have theoretical knowledge why hypothermia works. It slows down the metabolism, it slows down all the reaction, the excitatory neurotransmitters, everything. We have many, many animal studies showing the improvement with hypothermia. We have several large human studies, and at last we have 15 years of great clinical experience with hypothermia. So should we change all of that based on one single study that showed no differences at all? I wouldn't.
Okay, well, I would, because even though the hypothermia has been really well accepted and also very widely used method, I really think that the future might be different. We need to bear in mind that hypothermia is associated with risk of side effects. And before he said, like, okay, hypokalemia or pneumonia, those are not really serious side effects. Okay, maybe, yeah, but this is not me or you getting hypokalemia, okay? This is an, I don't know, 75-year-old male with already damaged heart, with 5 other comorbidities, and basically with 1 foot already in his grave. And what might be very innocent for you or for me might be, you know, really represent a great burden for this, have that individual. I'm sorry to say that, but yeah. And so I agree that further studies need to be done, you know, just to refine the protocols and to define the subgroups that benefit from individual therapies. In fact, some hospitals in the Northern Europe already abandoned this hypothermic approach, and now they just cool the patients to the 33 degrees Celsius. And so maybe eventually we'll all put this ice age in the past where it belongs. However, whatever the future brings, I think that we can both agree on this one, that we should absolutely not regress to the pre-2002 style of care that does not manage temperature at all. Okay, thank you.
Thank you. I would just like to comment something. We plan to have these arguments. We are still friends after this.
No,
we
are
plan
friends,
to have
we're
this
friends.
just to have some interaction on the stage.
Yeah, so thank you. I think that this discussion should be called the Battle for Hypothermia. I would like to congratulate both of the presenters for excellent presentation, and I would like to their mentor to pose a comment or questions for them.
Well, thank you very much. First, I would ask you a question. Please raise your hands. Who would treat a patient after cardiac arrest with hypothermia? Okay, and who wouldn't? Well, Stella, I thought you were a really tough fighter.
No, you'll stop. I have just one study confirming my, you know, Contra side, and he has, like I said, a decade of really great clinical practice and stuff, but yeah.
Yeah, but maybe a comment from everyday practice. That study was really a shock for us. I started working in ICU in 2004, just a year after we started cooling our patients here in Ljubljana. And I thought, before you raised your hands, that I'll have to support Matic, because I really saw that your presentation was excellent, showing the study and how nicely it was done. But when I came to my department, the nurses told me a story, what happened with these patients in 1990s, and also we had some numbers to support their sayings. When the patients after cardiac arrest came to the ICU, most of them didn't wake up at all and they all died. So actually the prognosis was really poor. The numbers were showing that between 1995 and 97, the mortality rate was really high. Only 40% of people survived hospital discharge, and out of them less than 25% had good neurological outcome. That means that 60% of patients died, and out of those 40% that survived, half of them were severely damaged. That means that they were maybe not even, they were in coma or so on. So actually they didn't have any quality life, although they survived cardiac arrest. After starting to use hypothermia, the numbers in majority of European centers went up extremely. In Ljubljana, compared also to Copenhagen or Stockholm, that centers that did TTM study, the numbers went up, the survival rate went from 40 to 70%, and more than 50% of patients after the all-comers survived with good neurological outcome. And compare the mid-1990s to 2005 to 2007, let's say, only two major things changed in our everyday practice, and that's the induction of hypothermia and the use of percutaneous coronary intervention, because we know that more than half of these patients suffer from acute coronary syndrome. We still, at the moment, don't have a study showing, a prospective randomized study showing that in this population that primary coronary intervention is beneficial. We have data from acute coronary syndrome studies, but we still use that in our population. And of course, we did have data even from before 2002, especially animal data, that hypothermia is beneficial. So actually, what happened in 2013 then, that a study came out showing that actually we don't get any benefit from inducing hypothermia, then how come we do have twice as good results as 15 years ago? what did change, if not hypothermia? And of course, the physicians that are using hypothermia started to look more into details into the so-called TTM trial, the temperature target management. And there are a few things that are not actually real life, because let's say if you look at just Europe, annually we treat around 100,000 people with out-of-hospital cardiac arrest in hospitals in Europe. And if you say that we have around 70% of survival, the numbers are really huge. In 10 years' time, we have 1 million people treated with hypothermia in Europe. And of course, there are no major side effects, because otherwise people would start talking. We get people with severe hypokalemia. We do see hypokalemia, but it's mild and clinically non-significant. We see that we maybe use more antibiotics in patients with hypothermia, but of course they don't die at the end of pneumonias. So if you look at your study, the temperatures were really close together. And also one thing that is bothering us, and maybe also other centers in Europe that are still using hypothermia, in TTM trial you saw that after 72 hours they started withdrawing therapy. That means that some of the patients that didn't wake up on day 3, they said, we'll stop the treatment. We have data also from our center. Before using hypothermia, majority of the patients would wake up in the first 72 hours because we used less sedatives. Because if you didn't treat them, you didn't need to sedate them. You just had to wait before and wait when they will wake up from their coma. But after using hypothermia, the median time of patients to wake up is 5 days. And on average, it's a 48-hour delay compared to the pre-2002 era. So majority of patients that are hypothermic wake up after 72 hours. And if you implement a protocol saying after 72 hours, we'll stop the treatment in those patients where we think they won't wake up, you can lose that number that could be statistically significant in the hypothermia group. Of course, because nowadays still we don't have any prognostication tool that would say we have a comatose patient after cardiac arrest. Let's do EEG and see whether his brain is injured. We can get pathological EEG, but still the patient will wake up without severe neurological damage, and we can get a perfectly normal exam, but the patient will stay in coma forever. So there is nothing, even CT scans or MRI or nothing is reliable after cardiac arrest. So the only thing you can do is wait for the patients to wake up. So this is one of the major, maybe, flaws of the last study. So all the centers, majority of the centers are still using hypothermia. Still, of course, I agree that we still don't know what is the optimal patient temperature. Maybe we should treat individually. So maybe if you would come after cardiac arrest, maybe your ideal temperature for your body would be 32, maybe for me 34, maybe for him 36. We know that we have to treat hypothermia, but still, how long we should treat, what is the target temperature, these questions are still unanswered. So maybe some questions from the audience.
Are there any questions from the public?
Okay, lunch then.
Yeah. Thanks again, and see you after lunch.
few boring Yes, sir. Okay. For the beginning, few boring facts about acute cholecystitis. That's a sudden inflammation of gallbladder, mostly caused by gallstones. It usually occurs in females, therefore we have this acronym 4F, female, fat, fertile, and 40. It's a very common disease in Western countries and has a huge socioeconomic impact on finances because of treatment cost and sick leave absence. So, Matos, can you tell us something about clinical picture of this disease condition?
Yeah, thank you, Nedo. Acute cholecystitis usually presents with pain in the right upper quadrant and also in the epigastric region. The pain can also radiate towards the right shoulder, and this is known as Boas sign. This pain can be accompanied by nausea and even vomiting, and if patient has jaundice, this is a sign of developing complications of acute cholecystitis. Of course, patients have also anorexia and fat intolerance, but the main complaint is about pain. So, Nedo?
So how do we treat? Very simple, with surgery, which is called cholecystectomy. That's surgical removal of gallbladder. There is two types of surgery, open one and laparoscopic, and today we'll focus more about laparoscopic. There is two approaches, early surgery, which is performed up to 48 hours of clinical onset, and delayed one, which is performed from 48 hours till 6 to 9 weeks of clinical onset. So, which brings us to the question, why are we here today?
Yeah, why are we even having this topic? As you can see from my slide, the surgery went a long way to reach the standard and level at which we know it today. However, with the introduction of evidence-based medicine, it has become really hard to change clinical practice. Gallstones have been known for thousands of years, and also the problem with acute cholecystitis. However, it was only in the end of the 19th century that the first open cholecystectomy was made by a German surgeon. And even 100 years later, in 1985, the first laparoscopic procedure was made. And if we link these two facts together, here is the next question. Ever since the development of laparoscopic cholecystectomy, there has been a discussion. What time should this procedure be performed? I hope that you will enjoy our debate, as each of us will try to show who is bigger.
So I'll try to convince you why is ELC better than DLC, delayed or early surgery. For the beginning, as I said on the first slide, it's a huge socioeconomic impact because of cost and hospital stay because of sick leave absence on a work job. So first, shorter hospital stays, 2 times less, 4.5 days comparing with 10 days. Also, study made in Canada showed that early surgery is much cheaper than delayed one. From $800 to $2,000, and also the same study showed that full implementation of early surgery would save up to $9 million a year. It's connected with lower morbidity.
I'll argue.
Try. I have. It precludes risk of recurrent gallstone symptoms because it's operated after clinical onset. We don't wait. It's connected with better quality of life, shorter recuperation time, and earlier return to workplace. Try to defeat me.
Yeah, I think that won't be so hard.
We'll see.
Yeah, we'll see. Okay, I'll present the first fact. Now, you heard Nedo said that early is 48 hours and delayed is 6 to 9 weeks. Yeah, that's basically true if Nedo is talking. However, in the randomized controlled trials, there is a problem with the definition of early surgery, because in this meta-analysis that was published in 2012, we can see that early is defined as from 72 hours to 1 week after onset. Only in one controlled trial, early is defined as 24 hours after randomization. The next study that I would like to point out, and from which this table is this one. As you can see, also in this meta-analysis, early is defined as from 4 days to 7 days after onset, and that's not even close, 48 hours. As for the longer hospital stay, yes, I think that the article that Nether read was, I don't think that he came up with it, because some articles say that. However, I would like to point out this article in which we can find this table, and we can see that the length of hospital stay is the same for early and late surgery of approximately 5 days, and there has been no statistically significant difference. Is ELC really better? Yeah, Nedo argued that morbidity is lower in the late surgery. Yes, Nedo. Also, I think that you've read an article, but here is one that also included Slovenia. It was a multi-center meta-analysis, and here we can see that in terms of morbidity score after 75 days, there has been no statistically significant difference. The only statistically significant difference that there has been is this one: pain and occurrence of cholangitis and cholecystitis. As far as pain is concerned, I would like to present you the next randomized controlled trial, which also took account, which was from a single center. And as we can see here, this one is, the pain management was actually better in the delayed group. So that's for the morbidity score. And as far as acute cholecystitis and cholangitis go, I think that it's logic that acute cholecystitis and cholangitis will occur if we do not cure the cause of the disease, which are the gallstones. However, will this occur within 48 hours after the onset? Hard to say. Now, I hope that you that are listening to me already asked yourself this one very important question. What do we gain if we wait 48 hours? I think that it was shown in this meta-analysis that was already mentioned earlier that the operation time in early surgery is longer for approximately 18 minutes. Because if we wait and we pharmacologically treat the patient, we get a better view of the operating field, and also the patient is more stable. This contributes to the fact that the operating time is lower. I would now like to present you with the forest plot from the next meta-analysis, from this one. As you can see, operating time in early surgery was significantly longer, and thus this forest plot favors delayed surgery, which is also true for the next meta-analysis from Hong Kong. And here's the forest plot. So, the next thing that I would like to argue, sorry Nedo, not your turn yet.
Yeah, I know, I see.
Is the conversion of the procedure to open cholecystectomy. Because with the beginning of the laparoscopic surgery, the conversion rates from laparoscopic to open procedure were quite high. Even 20% were recorded since 1990s and 1995. And this is no longer the case, except, I hope that this is not me in 5-year time, there is a learning surgeon, because it was shown in 1997 by this meta-analysis that all the conversions that were made in this meta-analysis were done by learning surgeons, and learning in this terms mean that the surgeon has less than 25 procedures under his belt. So now we do have to ask ourselves, if any one of you were to be operated and the learning surgeon was there and not the expert one, wouldn't you rather wait for Professor Tomažić that he operated you? I would.
Well, this everything sounds really convincing and good, but I have to warn you, Matis, that your data, that your info is out of date. While you were reading and quoting meta-analysis from 1997, I will start my counterattack with study published in July of 2013, and that study showed that there is no difference in conversion rates. They are only performed from different reasons. As you can see on the slide, in early surgery it's performed because atelmatous gallbladder, and in delayed because of adhesions and difficulty in gallbladder exposure. And also the study showed that waiting can be really dangerous because time has changed from 1997 to 2013, because this study showed that with waiting for 6 to 9 weeks to operate, we treat that patient with antibiotics and supportive care, but there is a higher risk of another acute cholecystitis, which can lead to deadly cause. So they said that it should be operated while it's hot, meaning in a time period of 24 hours. So What do you have to say on this?
Yeah, I would like to add that, yeah, I think that if you wait 6 to 9 weeks, that basically there will be some fibrosis, but this isn't our topic. Our topic is about 48 hours. And another thing that all of this...
But you are defending that we should wait.
Yeah, that we should wait longer than 48 hours.
Yeah, but then it's a delayed surgery. It doesn't have to be 6 weeks. It can be 1 week, but you have a higher risk of another inflammation.
Yes, you have a high risk if you wait too long. But if you wait 48 hours, even the first stage of acute cholecystitis wouldn't be over. Man. Yeah, that's a problem. Now, another thing that all meta-analysis lack is the inclusion of comorbidities and high-risk patients, because from all meta-analysis, patients that were considered poor medical candidates for surgery were excluded, which means that if you have suffered a heart attack and you are now living, you were not included. And even an author of an article which was in favor of early surgery said that with patients with high morbidity, it is wise to wait in order to get their liver, renal, and cardiovascular function back in shape and then operate them.
Yeah, well, before we skip to the conclusion, I have to interrupt you one more time, because I read a study from 2007 in Canada, and that study showed that even a high-risk patient with heart failure, diabetes, or renal dysfunction can be operated with laparoscopic surgery if they have good preoperative and postoperative care. So I think I nailed you, man.
Yeah, you've nailed it, but again, it's just laparoscopic surgery. There's no time window at which the surgery is performed. However, let's skip to conclusions, and I give it all to you, Nedo, now.
Thank you. So, as you could hear, both procedures have their good and bad sides, but the decision which one will be performed is up to surgeon, depending on his own experience, hospital transition, and possession of newest operating equipment. So, that's it, folks. I hope you enjoyed.
Yeah, me too.
Thank you, Nedo. Thank you, Matos, for this beautiful presentation. Now, I'll just also ask Professor Tomislav if he has any comments on the topic and also on the presentation, maybe.
I congratulate you. You really did a great job. So you said everything. I have nothing to add. Of course, maybe cholecystitis, this is some topic exactly for pro and contra. Because years ago we did delayed surgery. On opposite to acute appendicitis, which was operated still now and was also years ago immediately or as soon as possible, acute cholecystitis we treated conservatively with antibiotics. And then later with this laparoscopic surgery, we started also to operate on acute cholecystitis earlier. And then we found, on our experience, that it was easier to operate soon, on day 1 or day 2, because the inflammation was not so severe, and the structures were still possible to find. And on day 3 and 4, it became not so easy. After, let us say, week 2 or 3, the acute cholecystitis disappeared, and it happened. These patients were treated like chronic cholecystitis. The operation was again a little bit easier. But this is, you cannot say on your own experience. What we have to look are these randomized controlled trials. And we did participate in one of these trials. Matos showed with one group from Germany, where we treated one part of patients early and the other part late. The other part was put on antibiotics. But this study, you saw the results. I think we still don't have the final answer, because both are right. Of course, it depends on the skill of the surgeon who is working on duty. In our country, we are lucky because also experienced surgeons work on duty. On the opposite, you will see in I don't know, United States or somewhere, maybe in Great Britain, you will find only younger surgeons who will probably wait till morning or till next day. So this was congratulate you again. You did a really good job, both.
So, do we have any questions, maybe from the public? Okay, so we can go.
A question, maybe?
Yeah, sorry.
If you may. I would like to ask, now we are talking about laparoscopic surgery. What about open surgery? Is it still a reality or not?
Yeah, open surgery still is a reality. We try to do as much laparoscopic as possible, of course, but if we have, let us say, very sick patient with a lot of comorbidities, maybe with peritonitis, in septic shock or something, maybe with perforated gallbladder, then sometimes we decide to do the open as the first choice. But usually open is the like like conversion. We try to do it laparoscopically, but then because of inflammation or maybe bleeding or something, you cannot do it laparoscopically, then you do it open. But there is still some small percentage of patients who are treated as the first choice open. Let us say in our hospital, less than 10%, maybe 5%.
Hello, Nedo, one question for you. You mentioned that the early surgery is cheaper. So do you maybe know, did the study explain why it's cheaper? Is this because of the sick leave that was included, or was there some approaches needed because of the early operation?
It's also because of less sick leave absence, but also because it's shorter hospital stay. So even if after early surgery you need to make conversion, it's also cheaper than to wait because of price of antibiotics, of those supportive therapy and everything.
So no additional approaches were needed?
No, no additional. It's basically the same technique, you know, but with delayed you wait for 6 weeks and you treat with antibiotics, and with early you just go under the knife and it's surgically removed.
So everything was incalculated?
Yeah.
Okay, thank you.
You're welcome.
Okay, if you don't have any questions, I'll thank you again for these beautiful discussions. And I also will give my word to my colleague, Neža Žorž.
So we'll continue with the next debate. Laparoscopic inguinal hernioplasty is a better operative procedure in comparison with open tension-free hernioplasty. I would like to invite the debaters on stage. Pro, Julia Feradova, Faculty of Medicine, Medical University of Pliven, Bulgaria, and Contra, Mičo Božić, Medical Faculty, University of Ljubljana, Slovenia. Mentor for this debate is still Associate Professor Aleš Tomažić.
Dear colleagues, before we start talking about hernias and their treatment as a whole, we need to refresh our minds and remind you some anatomy. I think we all remember that the inguinal canal is a 4 centimeter long canal that has 4 walls and 2 openings, the superficial and subcutaneous inguinal ring and the deep ring. But the walls maybe you don't remember because they're quite far in our course. The posterior wall was made up of the transversalis fascia and the conjoint tendon. The anterior wall, it is made of the internal oblique muscle and the aponeurosis of the external oblique. The floor is made up of the ligaments you know well, the inguinal ligament or the so-called Poprad ligament and the lacunar ligament. And you have the roof made up of muscles. These are the internal oblique muscle and the transversus abdominis. Also, the contents is important because in both sexes we have the ilioinguinal nerve and the genital branch of the genitofemoral nerve, but in males we have the spermatic cord and in females the round ligament. Of course, for a surgeon it's important not only to know the anatomical structures, but some areas of risk like the Hasselbalch's triangle, the circle of death, the triangles of doom and pain. The Hasselbalch triangle is important to know because it's the weak place area in the transversalis fascia where hernias can occur, and of course the corona mortis, you know well, it's an important anastomosis between a normal obturator artery arising from the internal iliac artery and extra obturator artery. It can be very risky during surgery. And the triangle of pain and triangle of doom, they're important because of their contents. You have very important nerves in the triangle of pain, such as the femoral nerve, the cutaneous femoral nerves, and the femoral branch of the genitofemoral nerve. In the triangle of doom, you have the external iliac arteries, which are very risky during laparoscopic surgery especially. And now when you know more about the anatomy, we can talk about hernias.
Yeah, as you know, hernia is an abnormal protrusion of intra-abdominal tissue through a defect in the fascia of the abdominal wall. A vast majority, that is to say around 75% of hernias occur, of the abdominal hernias occur in the groin or in the inguinal region with a vast male predominance. Clinically, we can divide them into reducible, incarcerated, where we cannot remove, where we cannot reduce the hernia back into the abdomen, but the blood supply to the bowel is still not compromised, and strangulated, which are surgical emergencies. Anatomically, we can divide them into indirect, where the hernial sac enters through the internal inguinal ring and extends partway or throughout the inguinal canal. It occurs because there is failure of obliteration of the processus vaginalis in children. Around 2/3 of all inguinal hernias are indirect. They can present both congenitally or can be acquired later in life. An often clinical picture is that an older patient presents with a symptomatic indirect hernia because increased age is also linked to risk factors for an inguinal hernia, such as obesity or increased intra-abdominal pressure due to straining and other chronic disease. The other type is a direct hernia, where the hernial sac passes through a weak point in the transversalis fascia. As we heard, it's called the Hasselbalch's triangle, which is medial to the inferior epigastric vessels, and it represents 1/3 of all inguinal hernias. So that is the other third. They're always acquired. The principle of treatment for inguinal hernia is that all symptomatic hernias should be operated to avoid strangulation and the need for an emergency intervention.
Inguinal hernia repair is one of the most common general surgery operations. That's why it's important to know that there are many techniques that can be used during the treatment.
And as Julia said, this created great confusion as to which operative technique should be used. Nicholson, in his article in the British Journal of Surgery in 1999, put this beautifully in, and I'm going to quote a few sentences from that article. It goes, with over 8,000 groin hernia operations carried out in the UK alone each year, and a deepening crisis in surgical manpower resulting from increased surgical subspecialization and greater public and political demand for quality in surgical practice, inguinal hernia repair will remain for the foreseeable future a procedure likely to be delegated to non-consultant staff. It's essential, therefore, that we design safe and simple pathways for managing these patients. The hernia repairs are roughly divided into tension, where we fix the defect in the abdominal wall by suturing together the tissues themselves, or the tension-free, where the defect in the abdominal wall is usually covered with an application of a mesh, and these are then further divided into open. So an open tension-free mesh repair, which is the gold standard in inguinal hernia care, is called also a Liechtenstein repair, and in the laparoscopic ones.
Before we can talk about the advantages and disadvantages of the treatment options, I think it's good for you to see what we're talking about. And in the first video, you'll see the laparoscopic approach to hernia repair. This is a transabdominal hernia repair. I don't know if the video will start.
Okay, we're having some technical difficulties.
Oh, it's not
Maybe
playing.
you can explain it.
Okay, during laparoscopic repair, you have, of course, the laparoscopic approach, which is a safe approach to the abdominal cavity, and you have 3 trocars and 3 small incisions that allow you to enter the abdominal cavity. Once inside, you make the peritoneal incision and create a peritoneal flap. You gain access to the inguinal canal and to the hernial defect. Here in the video, you would be able to see what the indirect hernia looks like. It is important to know that the mesh we use is a polypropylene mesh sized appropriately so that it covers the direct, indirect, and femoral places for future hernias, possible hernias. During the transabdominal approach, you can also see if there are any occult hernias or any other defects, and you can repair them meanwhile. And there are 2 options for laparoscopic repair. This video would show you the transabdominal one, but there is another method for laparoscopic repair, and this is a totally extraperitoneal approach, where you have preperitoneal dissection of the hernial sac and mesh placement without entering the abdominal cavity at all. You create a superficial space where you can put the mesh.
Okay. And here. Oh, okay. You would be able to see Liechtenstein repair, which is, as I said, an open tension-free mesh hernioplasty, where the floor and the internal inguinal ring are reinforced with a polypropylene mesh. An incision is made 1 centimeter above and parallel to the inguinal ligament. The external oblique aponeurosis is opened up, and the inguinal canal is visualized. The spermatic cord is lifted up. The hernial sac is managed, for example, with resection, and the mesh, which is prior to a placement, trimmed, and a slit is created to create 2 tails. With it, we wrap the spermatic cord and create an artificial new inguinal ligament comprised of mesh. We anchor it close to the tubic tubercle, but we have to be very careful not to touch the periosteum, and the mesh is then sutured to the free border of the inguinal ligament. In this operation, we have to take great care not to injure any of the nerve structures that we mentioned before, because chronic post-operative pain is one of the most common complications of this procedure.
If you had been able to see the videos, you would see that the laparoscopic procedure is much less invasive, because you have 3 small incisions instead of a wide groin incision. That's why I'm actually pro laparoscopic repair. Oh, okay, this is the video. Maybe you would like to have a look. This is the indirect hernia, and you have to find the anatomical structures we already talked about. Here's how the peritoneal flap will be created and access will be gained into the inguinal canal. And this is incision that is being extended with the laparoscopic scissors. And you use the Gašper during blunt dissection of the peritoneum. You must, during the retraction of the peritoneal flap, you actually can reduce the hernial sac. And, okay. Here you are into the inguinal canal, and you'll see the polypropylene mesh that is sized properly according to our needs. It will be rolled longitudinally so that it can be introduced into the abdominal cavity using the Gašper and the trocar from the by the surgeon. And here, once inside the abdominal cavity, it is spread so that potential hernias do not occur in the future. It must cover well the potential hernia sites, and it is attached to the Cooper ligament and to the pubic tubercle using a stapler. It is important to be attached correctly and properly, and not injure any nerves or vessels. This is an important point during the surgery. This is the peritoneal flap that is also attached to the abdominal wall using a stapler, and it must cover the mesh very well. And this is the laparoscopic, transabdominal laparoscopic hernia repair. I don't know if we'll see the open repair.
Okay.
Okay. This is
the other operation. Here we're just going to show you a quick video of the key step that sets apart this operation from the other ones, from the other open ones. That is the placement of the mesh. As you see, the mesh was first trimmed to conform to the patient's anatomy, and two big meshes were also increase the risk of folding, which can cause nerve damage, and meshes that are too large place the patient at an increased risk of infection. As you see, the spermatic cord is lifted up. The mesh is first anchored medially close to the pubic tubercle, and later on it is sutured, as I said, on the free border of the inguinal ligament. Okay.
Now you have an idea what is the difference between the two operations, and we can go on with the advantages of laparoscopic repair. Yeah. Literature says that laparoscopic hernia repair has decreased morbidity, which is a very good advantage instead in comparison with open surgery. But also the post-operative pain, the main complaint of all patients, is decreased here, both acute and chronic pain. The chronic pain including neuralgia, paresthesia, and hypo or hyperesthesia. Also, it is very important for the patient to go back early to work, and here the recovery time is around 1 week, although both procedures are same-day procedures. But in open repair, you have 4 to 6 weeks of recovery, and here only 1 week. Yeah. And maybe here it's good to point out that in the two laparoscopic methods, you have similar operative results. Although the TEP repair has decreased operative morbidity, still surgeons think that the TAP repair, the transabdominal you watched, is easier to learn and to teach.
Okay, and I'm going to point out the main disadvantages of laparoscopic inguinal repair. The first thing that I would like to say is that even though rare, there are potential serious complications in the laparoscopic repair. For example, the damage to the viscera, for example, the bowel and the bladder, and for serious neurovascular injuries. Even as we heard, these structures are in the anatomy of laparoscopic surgeons referred to with names as triangles of doom and pain. With the transabdominal preperitoneal approach, which is the most commonly used laparoscopic operation, we even have to enter the peritoneal cavity, which can be easily avoided if we use any open approach, which I think it's clear that here we automatically increase the patient's risk to peritoneal infection, so that is to diffuse peritonitis and even the sepsis. And the other thing that my colleague said is that even though that the rates of recurrence are comparable for open and laparoscopic repair, that is true if we're talking about experienced surgeons. With unexperienced surgeons, there is a higher rate of recurrence for inguinal hernias, and also there is more serious complications. And why am I pointing out this word unexperienced? Because this leads us to a second great disadvantage of laparoscopic hernioplasty, and maybe even to laparoscopic surgery in general. That is that these operations are harder to learn. That is to say, there is a steeper learning curve. It is said that for TAP repair, a surgeon should do around 200 operations before he can be proclaimed as experienced, whereas in comparison, the Liechtenstein repair, the caseload is around 5. The next thing is that here the patient needs to be put in general anesthesia, and the operation times of laparoscopic repair are longer than for open operations, which of course puts the patient to increased risks associated with general anesthesia. And the last thing I would point out that these techniques are also associated with increased costs to the hospital, because there is need for highly specialized equipment. and for expert staff.
Having in mind the benefits for a patient and it's his recovery, past recovery, and going back to work early, I think the cost is not that important here. And also the experience you said about experience, yes, it's very, very important, but I think we are lucky to have very experienced laparoscopists now who can train us. For example, in my school, we have a laparoscopy school for students even. So we start laparoscopy very early. Yes. As you see, the evidence is actually very controversial and equivocal. I mean, maybe the surgeon's preference will continue to be the leading factor in choosing between laparoscopy and open repair. But nowadays, we have some indications and contraindications in which laparoscopic hernia repair is beneficial and it's proven, and all surgeons go on with this. I mean, they have them in mind. These indications include a recurrence from a prior open inguinal hernia repair, because here you can avoid scars and some additional defects that occurred during open surgery. Also, the bilateral hernias can be easily repaired by laparoscopy because you use the same ports and you don't have to you don't need a second surgery. Also, uncertain diagnosis. Here, laparoscopy is very useful because you can put the diagnosis and treat the patient at the same time. In obese patients, laparoscopy is preferable because you don't have a wide incision, because they are susceptible to infections, and it's much harder to repair these patients' hernias. And also, patients who want to go back to work or to their physical activity early, it's better to choose laparoscopy because in laparoscopy you put the mesh posterior to the abdominal wall, and if they want to go back early and they try physical activities, the abdominal pressure is very high, but still the mesh is pushed against the abdominal wall, not like in the open surgery, it's anterior to the wall.
Okay. But these are very specific cases in which the laparoscopic surgery is indicated, so I'd also like to point out the opposite, where there are specific contraindications for laparoscopic hernia repair. These are, as I said before, an increased risk of general anesthesia. This makes these kinds of repairs unsuitable for older patients or with patients with other significant comorbidities like cardiac or pulmonary. The patients who have history of abdominal surgery should be operated via an open repair, because with previous abdominal operations there is an increased risk of intra-abdominal adhesions, which greatly reduce the visibility and also even further predispose the patients to serious complications, that is to injury to the viscera or to the neurovascular structures. And the patients who had a recurrence from a prior laparoscopic repair should be operated with an open repair. Strangulated hernia is also a contraindication for laparoscopic surgery, but it is also a contraindication for an open tension-free mesh repair, as in these circumstances we should avoid putting any external material, because it can be a new focus for an infection and for a formation of an abscess.
As you see, it's very hard to actually debate on this topic, because if you have laparoscopists, experienced ones, and if you have the instruments, it's very easy to try laparoscopic access. And while we were looking for information, we found a cited from the Basic Surgical Techniques book, which says that nowadays people just need some guidelines to lower the risk about their patients. And I think the indications and contraindications are just a part of these guidelines that are going to be set in the near future. Thank you for your attention.
Thank you.
So thank you, Julia. Thank you, Micho, for this debate. It was very interesting. Firstly, Professor Tomažić, I would like to ask you for your opinion on this subject.
Yeah. I started to do laparoscopic procedures a few years ago. I don't really know why. I am a big fan of laparoscopic surgery otherwise, so I do a lot of colorectal and other kind of surgeries, but I was reluctant to do the hernia laparoscopically, because you can do hernia also through small incision in groin, and you put a mesh, so I didn't really see big pro for laparoscopic hernia repair. But then I changed my mind. also this happens. I agree completely with what you said. This TAP procedure is easier to do than TAP, so we started with TAP. I will tell you why, and I also agree with this, that this should do an experienced surgeon, because otherwise you have big complications like these vessel injuries, bowel injuries, and bladder injuries are very severe, let us say, bad sides of laparoscopic hernia repair. On the other hand, if you do it laparoscopically, you only cut the peritoneum. You don't cut any other structure. Just cut the peritoneum and put a mesh between the wall of the abdomen and between the peritoneum. But if you go from the front side in the open repair, you go through a lot of tissue. You go through muscles, is higher incidence of nerve injuries, and that's why it's bigger pain, and this patient get later to normal activity compared to laparoscopic group. So that's why I became a fan of laparoscopic surgery, but still there are this, all they said is true. I think more kind of this surgery will be done open still, because young surgeons have to learn, and because it is easier, and it is, I think, also a little bit cheaper and faster. But in my hands, if I would do an open or laparoscopic surgery, I can, let us say, guarantee you it would be better with laparoscopic than open. But the difference, I hope, would not be great, but you would start earlier to go running or do anything. Thank you both. You also said everything to us. And the movies were, I think, the key point for them to see what is one operation and what is the other.
Thank you. Are there any questions?
Hi. Thank you for a very interesting presentation. I would just like to share an experience I had from a student exchange. It was though in pediatric surgery, but as you know, they do a lot of inguinal hernia repairs. And they did not use a mesh. They used like a bendable needle that goes around the neck of the hernia, and they just tie it like a sack. And it really seemed like so minimally invasive, and they had zero like recidives. And it was a day type of surgery, so a child would come in, they would do it, it would wake up from the anesthesia, they would monitor him for a few hours, and then he would go home. So, yeah, go for the laparoscopic surgery for me.
Also, we do it in children, and also in children we never put a mesh. It is children. The type of surgery in children is a little bit different than in adults. So we never use meshes in children, and we also do it laparoscopically.
Any other questions? In that case, thank you.
Thank you.
Thank you.
Okay, now we'll have a 15-minute break. So after that, we got like long-awaited hashtag award, and see you in 15 minutes.
Our story begins in 1851. That's 102 years before the discovery of the double helix, 77 years before the rediscovery of penicillin, and 85 years before Elvis changed.
So let's see if we spare the best for last. Please join me on stage for the first plastic and aesthetic surgery debate. On the pro side, Katarina Vujkovac, Medical Faculty, University of Ljubljana, Slovenia. And on the contra side, Ana Pejoska, Faculty of Medicine, Skopje, Macedonia. I would also like to invite the debate's mentor, Dr. Nina Suvaro.
So my name is Katarina Vujkovac, and this is my colleague, Ana Pejoska. And today we will be debating on a theme of visiting a few workshops gives me the authority to perform aesthetic surgery. Ready? So what does aesthetic actually mean? Aesthetic is an adjective, and it means of, relating to, or dealing with the beautiful, pleasing in appearance, responsive to, or appreciative of what is pleasurable to the senses. Derived from the word comes aesthetic surgery, which is a subspecialty and an essential part of plastic surgery focused on satisfying the aesthetic desires and goals of patients. There are many reasons why people opt for cosmetic procedure. This can either be good, for example, reversing the process of aging, fixing a physical problem, scars, sun damage, or bad, for example, aiming for perfection, satisfying someone else, getting back at someone, or even feeling depressed.
Well, Plato once said, there exist 3 wishes all human beings have: to be healthy, to earn money honestly, and to be beautiful. And the job of an aesthetic surgeon is to change this into this, to define nature and reverse the process of aging. Now, we would like to take a look at this short video we prepared for you. Have a pet like this. The couple, as you can see, had to choose a dog, and it wasn't a very easy decision. But how would you choose the right surgeon? What are our reasons? What we look for exactly?
As the patient should be the focus of every treatment, me and Anna decided to do a sort of mini-study. To put ourselves in the patient perspective, we prepared a short questionnaire to find out what really matters to the patients when they opt for a cosmetic procedure. Our target group were women aged 35 to 50, as they most frequently undergo aesthetic surgery. As you can see, in America, 91% of all aesthetic procedures are done on women, and 42% in this age group.
The women were asked to choose a surgeon performing aesthetic surgery from a list of 6 given surgeons. They were all presented with the surgeon's online pages. 3 of them have a specialty in plastic, reconstructive, and aesthetic surgery, and 3 of them don't. However, this was not pointed out to the women taking the questionnaire.
They were to rate all of the following by importance on a scale from 1 to 5. So, cost of aesthetic procedure, clinic size, traveling distance, online presentation, referral from a friend, referral from a general practitioner, surgeon's age, experience, qualifications, and resume. For the purposes of this debate, we were especially interested in the results of surgeon's qualifications, if he or she either has a specialization of plastic surgery or not.
Well, at this point, we would like to ask you guys, what do you think the perfect aesthetic surgeon should be like? Anyone? Something else? Okay. Nice. Thank you for your opinion. What we found out from our results, the perfect aesthetic surgeon is one with great renommee, has proper qualifications, has a lot of experience, and is referred to by a general practitioner.
And what was especially interesting, we found out that 53% of women chose plastic surgeons compared to 74% of women that chose non-plastic surgeons, which is a minor difference regarding the fact that 38 women answered the questionnaire. Here you can also see the difference between Macedonia and Slovenia. Macedonians based their decision mostly on surgeons' experiences and actually chose more non-plastic surgeons. On the other hand, Slovenians did the opposite. Is it because they are better informed? Or Macedonians exposed to a higher number of ads because they have a greater number of surgeons performing aesthetic procedures and the competition is tougher? Following our results, we found out the patients value surgeons' experience the most. 74% of women chose this to be absolutely critical. Somewhat unsurprisingly for such small countries is the fact that renommee showed to be a very significant factor when choosing a surgeon, which can be connected to the fact that a lot of satisfied patients spread the word.
Yeah, Katerina, but the study we made was based on visual perception. And the surgeons that don't have required specialization have much better online presentation, lower prices, better advertisements. Well, that's how they increase the inflow of patients and thus money. Aesthetic surgery has become very lucrative business where people are manipulated by visual stimulations, whereas they forgot how skillful and well-trained you have to be to perform such an operation. Okay. 71% of women choose surgeons' qualifications to be absolutely critical. But what do we have on the other hand? 47 of them chose surgeon without proper education. Is this indirectly related to a good online presentation? This data shows how easy manipulated we can be. And also renommee. What does renommee actually mean? Widespread reputation, which consists of spoken word and media. Manipulation, again.
Yes, but why not base our decision on years of experience and reputation? What we should all fear is this. This is an example of a very inappropriate email that guarantees you a degree in 2 weeks, even PhD, no studying required. Sounds so tempting, Hannah. Maybe we should just open a clinic together in 2 weeks. If you say that we can be manipulated by media and online presentations, do you think we can't be manipulated by this? In this case, it is also better to choose a surgeon based on experience and reputation than on qualification of a self-proclaimed aesthetic surgeon. It is also always necessary to be cautious, and I think we can both agree that these kind of practitioners are the real danger here.
Oh, you can't even imagine how dangerous they could be. But I'm here to show you. There will be a short video facelift. Be cautious, it is not recommended for faint-hearted. Okay, thank you. As you could see, the facelift procedure is pretty difficult, and this kind of procedure should not be taken lightly, as failed procedure results in deformity. You have to be very precise, especially on the face area. You might ask me, why especially on the face? Because of this. Let's remember some basics anatomy. As you all know, anatomy is a basic subject of all surgery, and surgery in the area of head and neck could not be taken safe unless surgeons thoroughly understand the anatomy of the area with all of its variations. So what do we got here? A lot of muscles, nerves, and blood vessels, such as supraorbital nerve, infraorbital nerve, parotid gland. We also have facial vein and artery. We have mental nerve, levator anguli oris muscle, depressor labii inferioris muscle. We have auriculotemporal nerve, zygomaticofacial nerve, and the most affected structure during facelift procedure, the facial nerve, with all of its branches. If the facial nerves got injured, you may end up like this. Shocking, right?
Very shocking, Anna. But a surgeon with a specialization in ear, nose, and throat, which is what ENT stands for, spends a great fraction of his training mastering reconstructive and plastic surgery of the head, neck, and face, and becomes, after 5 to 6 years of surgical training, a regional expert in the anatomy of the area, not to leave out maxillofacial surgeons. By visiting a few workshops, the surgeon just builds up the knowledge and is presented with new techniques that can improve possible outcomes. Just because someone is a specialist of plastic surgery does not make him free of mistakes, and an ENT surgeon or a maxillofacial surgeon that renew and add their knowledge by visiting workshops regularly can have far better results and is a safer choice for the patient than a plastic surgeon that only grasps to his professional title.
Well, while this can be true, Katarina, still, ENT surgeons in Slovenia spend only 1 month out of 60 months program at the Department of Plastic Surgery, which time they accounted with some core basics. Not to mention the fact that plastic surgery encompasses the whole body, not just the face and neck. Plastic surgeons have more experience with emphasis on plastic and aesthetic surgery throughout specialization under mentor supervision. They also are trained to recognize, react, and treat possible complications better by observing their mentors. Just to make things a little clearer, here are some photos of aesthetic procedures gone horribly wrong. These women chose the surgeon, as did approximately a half of women that answered our questionnaire on well-made online presentation and had a little concern regarding surgeons' qualifications. These were all surgeons without proper training, but hey, they have visited few workshops. The dream of women to be beautiful became into a nightmare, which brings us to the questions. How well informed are our patients, and is it fair to be manipulated on account of producing profit?
Of course not. And maybe you won't believe me, but even plastic surgeons make mistakes. Now, jokes aside, behind me you can see a photo of an abdominoplasty, or a tummy tuck as you might call it, performed by an all-board certified plastic surgeon. I'm showing you this because, inevitably, we must take into account surgeons' skills and talent, and, very importantly, individual patients' responses to surgery. This means that just because a surgeon has a specialty of plastic surgery does not guarantee 100% patient satisfaction or the perfect outcome. So, is there a solution to this dispute? At the moment, Slovenia and Macedonia have no laws or legislation that would concern aesthetic surgery. This means that any surgeon can perform aesthetic procedures without legal consequences.
To act responsible towards our patients, such regulative should be enforced. An example of a good practice is Denmark, with their legal regulation regarding cosmetic treatments. Behind me, you can see the summary of a Danish law with listed procedures and who can perform them. And as you can see, abdominoplasty, or tamoetak as you prefer to call it, and breast surgery, the most two frequent cosmetic procedures, can be performed only by a plastic surgeon.
Yes, but we must not leave out the information that also ophthalmologists can perform upper face lifts and blepharoplasty, which is eyelid surgery, and ENT surgeons can perform aesthetic procedures of nose and ears. Dermatovenerologists can perform most of the procedures involving skin, and Botox can even be applied, besides all those listed here, by a nurse under doctor's supervision.
So, to conclude, cosmetic surgery should be performed by plastic surgeons.
However, surgeons of other specializations can perform some of the procedures given that they're in the area of their expertise.
Thank you for your attention, and remember, true beauty is on the inside.
Thank you both. And before I give a word to the public, I would like to ask mentor if she could add some comments or few words.
Hello to you all first. I think everything that was really necessary was pointed out really greatly, and I congratulate you for this really great presentation that you made. I agree that certain areas, especially the face, should be touched also by some other specialities, but that should remain localized to these certain areas of their expertise. Usually that is not so, and this area expands toward the lower parts of the body, and that is what's wrong. So I think the whole body should be only touched by the plastic surgeon, and I will tell you two reasons why I think so. The first one is the decision making. We can look at the breast augmentation. If a young 20 years old girl steps in your office and she has these beautiful young breasts, which are a little bit small, like maybe a weak pickup, and she wants to augment the breasts to the, let's say, a full C. That's a really beautiful and straightforward operation that probably should be done also by a surgeon with some other speciality, with some short course of breast implants or augmentation. But unfortunately, it's not always, or most of the time, it's not like that. What if in your office comes somebody with chest deformity, with, let's say, breast asymmetry? One breast is a size A, another one is size C, ptotic, and so on. What if comes an older woman which not only has small breast, but she also has ptotic breast, she has too much skin, and everything. I mean, what I want to say is that the decision making is the key to a successful operation. So decision making means that whenever you see the patient, you decide what kind of surgery and technique you're going to perform. And that is different for each patient that steps into your office. It's not standardized, it's not always the same. And that's what I think that 6 years of residency gives you. The other thing which is really, really important is also that complications, which you also mentioned. So patient that comes to your office really trusts you, and they trust you with actually their life. I mean, because we know we can have also life-threatening complication with, let's say, liposuction. You can easily, how do you say that? You can go with a cannula into the abdominal cavity. You can perforate the bowel and so on. This can be a life-threatening complications that results with that. Patient also has the confidence in you that you'll be able, if they won't be satisfied with the result, to be able to repair or to get things better, because they come to you to get a better result, not to get a worse result. And I don't think that the training of 2 weeks will give you all the experience that you need to get to be able to treat this. So these two things, I think, are the most important, why you need to have the residency in plastic surgery. What do you others think?
Questions, maybe?
Yes, who would go for aesthetic surgery to someone that's not a plastic surgeon? Yeah. And I think that people are still, they don't know enough. I mean, and we have to do a lot through media, through all of them, to get the people to be more educated about who they go to and who they trust when they when they want the aesthetic surgery done.
Yeah, because as you saw, now everyone says, no, of course I will go to a plastic surgeon. But as you saw, the study we made shows that women aren't actually aware that the surgeon doesn't have a specialty in plastic surgery. It just says everywhere aesthetic surgery, breast augmentation, tummy tucks, and they are not well informed. That's the problem here.
Yeah, that was actually the point, to show how uninformed are people.
I mean, even among plastic surgeons, there's a big difference. Of course, someone that's fresh out of residency doesn't have enough experience to be able to perform all of the surgeries by himself or herself. Let's say I'm 4 years out of the residency, and still, I mean, there are plenty of surgeries, aesthetic surgeries, that I really feel comfortable to do by myself. But if I see a complicated case that I'm not really certain about the result and so on, I will always ask a senior mentor or for advice or to help me even with the surgery. And I don't feel that is like a weakness or something that you don't know, but it's actually how do you call it? You owe that to your patient because they trust you. And they trust you with their body and with something that will last forever, because sometimes the results you cannot repair. So.
Sorry for interrupting. Yeah, here. Hello. One of the points you made during the debate about the Danish model, I think, was the best one I saw so far from all the points. And it kept me thinking, isn't this supposed to be a legal problem that all the plastic surgeons should unite as a community and demand that there are more strict regulations for this? So it wouldn't be open for open discussion or for the public, but there are strict regulations. We know that abdominal surgery can't be performed by neurosurgeons because it's not their job. Thanks.
Yes, and I think we're going towards that. We're trying to do something like the Denmark, I think you said. So, but it's it takes time for this thing. The best thing would be to have a regulation.
Unfortunately, that is neglected in our countries. There are no regulatives, and that's such a shame.
We can just suggest the law, but we can't, it's not in our...
Has there been any sort of initiative so far?
Yes, the Danish law was translated into Slovene.
Yeah? And how did it fare?
I'm sorry?
How did it go? How did it fare?
Yeah, that's what I'm trying to say, because the politicians have to read it through and then...
To acknowledge it, and
yes.
There's also a big lobby from this other specialty that will try to, to refuse and stop this this law from being realized. I mean, being accepted. So if it would be so easy, also some other countries in Europe, it's only Denmark, and I think there's another one also, I don't know which one. I read recently, but I forgot. I think 2 countries in Europe have the regulation, and none of the else, they haven't. So it's not that easy.
Hello, I have more of a comment. On one slide it said neurologist does Botox. Yeah, but he doesn't do Botox for aesthetic reasons. He does Botox because, for example, blepharospasm or torticollis or something like that. So it's not actually,
yes,
you know,
but you would be surprised how these indications spread. I mean, also gynecologists do Botox, family practitioner, dentists, they do Botox. And there's no regulation for them not to be able to do Botox. Everybody does Botox whenever, whoever wants it. So you can do Botox if you want.
Hi, one more question. Okay, so let's say that you go to a plastic surgery and it goes wrong, or you're not just satisfied with the result. And then you decide you want another surgery. I mean, who pays for this? Okay.
Oh, it depends. That's a really tricky question. And some of the aesthetic surgeons, they refuse. They will always want from the patient to pay for another surgery. It's very different. Depends on the doctor itself, of the plastic surgeon. So my opinion is that if you see that you did the surgery suboptimally and there's really something that can be made better, I think there's nothing wrong if you do it. I think you should do it without cost for the patient and repair it.
Okay, thank you.
Hello, I would only ask how many patients have you met in your clinical practice that were operated by non-plastic surgeons from Slovenia and the patients had bad results?
It's very funny that patients usually don't want to talk to you about who operated them before. I don't know if that is just Slovenian thing, but I rarely get an answer about who did their operation before, except if I ask them directly, which I don't want to do because it's kind of, I don't know, I don't feel like asking them that, but they don't want to tell you usually. I saw some results not only from doctors in Slovenia, but also from other countries. A lot of our patients go also to Croatia, Serbia to be operated. So I've seen some bad results, and it's very ungrateful to repair those results. I usually counsel them to go back to their doctor because this surgeon that operated on them is the only one who exactly knows what they did, how they do it, and so on. So the best thing is to be able to correct your own mistakes by yourself. And if I, by example, correct after somebody else, and I don't get the result that the patient is satisfied with, then he will only blame me because I didn't achieve what he wanted. So it's really, these are difficult cases and you usually don't want to get involved.
Then I have to ask, isn't that like denying treatment for patients?
It's not denying treatment because it's not an injury, it's not, I mean, it's elective procedure and the patient has decided to repair something that wasn't wrong at all, you know what I mean?
Yeah,
and you always have, if you would consider, like you said, everything, then denying any patient would be wrong. But we got also patients that have unrealistic expectations that have body dysmorphic syndrome, if you know what that means. It means that somebody has some psychological problems and exaggerates the problem, which is really small, or there's no problem. Let's say with a nose, somebody comes to your office and you see a normal nose, and they will blow it out of proportion. And you know, this is not the patient to be treated, because he never will be satisfied, because the problem is not the nose, the problem is somewhere else.
Yeah, I agree with that. I'm specifically talking about patients that were massacred by other surgeons. They come to you, to a plastic surgeon, for correction, and you basically deny treatment because you don't want to get blamed for others' mistakes.
I understand. You mean, of course, if someone will come to you with an infection or with something, with a wound that's not healing or something like that, then you will treat him, of course. But if that is something regarding the shape of the, let's say, breast, or I don't know, the shape of the nose, or that's not actually treatment, because
I
there's
was more
nothing.
asking for a philosophical point of view, you know, not really, it's not a necessary treatment. It's
You must define what's a treatment here in this.
He was, the patient was dissatisfied with the results. So.
Yes, but you don't have to treat any of the aesthetic patient.
Of course.
If you don't want to, you don't have to.
Now, I'm talking from the patient's point of view, because in the end, the patient gets basically screwed because he gets ping-pong all around. Because in the first place, he was
it was his primary
informed.
choice, and he has to actually take the consequences of that,
yeah.
you know?
That's too bad, too bad. Thanks.
Let's continue with the second debate of the session and the final one of this year's Congress. On the pro side, I would like to invite Luka Tomšić-Ahčin, and on the contra side, Barbara Šijaković, both medical faculty, University of Ljubljana, Slovenia, to present their title. The word is yours.
Hello, it's me up again here. So I thought I could start with an old Marx Brothers joke. No wonder it looks like the same room, because it is the same room. Okay, it doesn't go. Since it's Saturday afternoon and this is the last debate of this Congress, we try to be as interesting and as short as possible. So my name is Luka, colleague on my left, Barbara, and of course already introduced our mentor Nina Suvaro, MD. Now, before we actually start with the debate, let us ask you one simple question. Now, imagine that you've lost your hand sometime in the past, for example, and you're now presented with two options, either hand transplantation or bionic prosthesis. So, which would you choose right now, this very moment? So, how many of you would choose hand transplantation? Just raise your hand. Just now, before you know anything. And what about bionic prosthesis? Okay. Almost majority of you. We'll keep that number in mind, right, Barbara?
Of course. I like this result. Before we begin, let's just clear some terms. Luka, would you tell us what is actually a reconstructive transplant?
Thank you, Barbara. A reconstructive transplant, or also called as a composite tissue allograft, is an operation that involves the transplantation of bones, muscles, blood vessels, and nerves. And according to WHO, a transplantation is a transfer, or rather engraftment, of human cells, tissues, or organs from a donor to a recipient with the aim of restoring function or functions in the body. Now, in several cases, it can also be performed between two different species, for example, animal to human, like a pig valve in heart valve transplantation, and in that case, it's called xenotransplantation. Now, Barbara, would you care to briefly explain to us what a bionic prosthesis is and how it works?
Absolutely, thank you. Bionic creativity engineering is basically implementation of biological systems into developing modern technology. So bionic hand isn't just the hook, it mimics the function of the real human hand. And in some cases, this bionic hand can even superimpose human one, and I'll show it to you later. Now, today we have several different bionic prostheses in the market, and I'll talk mostly about Ultra one. And here is how it looks. It's made mostly out of plastic and titanium and silicone. And we can see it has a switch button here. It has motorized digits. And just some specifics, like it weighs from 400 to 500 grams due to 2 types of batteries, depending on patient's needs. It can take the load of maximum 90 kilos and per finger 32, so that's not bad at all. It can have different covers. Those comes in different colors and different shades. They can have a vein relief if you want to. It can have hairs or without hair, whatever the preferences are. It can even have special acrylic nails that can be polished. And even though it seems ridiculous, but these are some things that are actually pretty important for patient self-image. Now, how this hand actually works? Well, Ultra is myoelectric prosthesis, which means it uses electrical sensors to detect contractions in the muscles, selected muscles, of a residual limb, and then those contractions are translated to bionic hand movement by specific algorithms.
Okay, so which is better? Let's start with transplantations of the hand first. Now, we will mainly focus on the hand since, let's face it, leg prostheses are nowadays nearly perfect. But with hand, it's quite the opposite and very different. You have so many small and fine movements that are incorporated in everyday's life, so you just simply cannot function without a hand. Now, here is a picture that shows the complexity of the anatomy that you have to keep in mind while performing the transplantation procedure. Now, just some short history for the beginning. The first hand transplantation was actually performed in Ecuador in 1964, but the patient suffered from a rejection episode only after about 2 weeks, and he lost his hand. Of course, there was no immunosuppression drugs used. Then there was basically a long period of nothing, up until January 1999, the first successful hand transplantation, but this time with the immunosuppression drugs to prevent any kinds of rejection. Now, you should notice here that we're talking about hand transplantation, not about replantation. The first successful replantation, on the other hand, was performed in Shanghai, China in 1963, so more than 30 years before the actual transplantation of the hand. So, in January 1999, the first person, the American baseball player, underwent this operation. Now, this kind of operation is probably one of the longest there is. It can take approximately up to 12 or 16 hours and more. And in comparison, a typical heart transplant takes about 6 to 8 hours, and a typical liver transplant about 8 to 12 hours. So hand transplantation is an extremely complex procedure, but still may not be as difficult as hand replantation, in that a replantation usually involves crushed bones or avulsed tendons, blood vessels, and nerves.
Well, look, would you care to elaborate on how this is done?
Yeah, sure. Well, in theory, it's quite straightforward. Now, how this is performed is shown in the video behind. The surgeon will progress with tissue repair in the following order. First, the blood flow is restricted by using a special tourniquet. And this is to enable the surgeon to easily manipulate with the surgical field during the operation. And once the blood has been successfully stopped, then of course the next step is the incision. And the incision is made to expose all the deeper structures. And once you reach deep down to the bones, the radius and the ulna bones are fixated with special metal plates and then screwed together, which is practically the same procedure as used in classic orthopediatric surgery. Now, once we have achieved this fixation of both two bones, the next step is the tendons, the repair of the tendons. First, the flexor tendons, and as you can see in the video, the tendons are pulled and therefore tested before the reconnection. This is just to make sure that it all slides accordingly as it should. And of course, the same process is then used all over again on the other side with the extensor tendons. And again, just to make sure that later the hand rests in a natural position so that it's not fully extended or fully flexed. The next step is to use a special microscope. And with this microscope, the surgeon can easily suture the nerves together, the median, the ulnar, and the radial nerves, as you can see in the video. And once the nerves have been successfully reattached to each other, The next step is the plumbing. Now, we try to make the anastomosis of the arteries. Of course, once we achieve both anastomosis of both radial and ulnar arteries, the next step are the veins. So the hand is once again pronated to expose the veins. And again, the anastomosis of the veins is performed. Now, the next step is to supinate the hand once again and release the tourniquet to enable the blood flow to start all over again. And the surgical team watches the change in color to pink with the return of circulation, and also they watch for the pulsations of the arteries just to make sure that everything went smoothly without any complications whatsoever. And of course, the last step is to close the skin.
Well, first of all, we must keep in mind that not all the amputees are suitable for hand transplantation. It is performed only in healthy individuals with normal life expectancy. And of course, even if the procedure itself goes well, the rehabilitation process is long and complex, and it usually, or it does, for the fact, take the whole team of medical specialists to be included.
Well, not really. It normally takes about 6 weeks for you to stay in hospital. In the first week, there's normally rest, of course. But in the second week, the rehabilitation starts. First, of course, passive movements, and then in about 3, 4 weeks or so, even active movements. And as I said, in 6 weeks after the procedure, the patients go home and they can perform easily everyday tasks without any problems at all.
Well, eventually, after those 6 weeks, our patient is at home. And we are coming to the most important issue here, immunosuppressive therapy. Tell us something about this.
Yes. Probably the most important part regarding the survival of the transplanted hand is immunosuppression. Nowadays, the therapy has much improved. Now, the old-fashioned way would be to use a trial regimen with tacrolimus, mycophenolate mofetil, and prednisolone. Now, we all know that using corticosteroids can have some serious side effects, so we try to eliminate the usage of such drugs as much as we can. So there is a new way of treatment and immunosuppression, and it's to use a special steroid-sparing induction regimen with alemtuzumab. Now, this alemtuzumab is a humanized CD52 monoclonal antibody, which is an effective depleting agent. And of course, we still use tacrolimus and mycophenolate mofetil, since those two drugs are very potent immunosuppressants. But we lose the prednisolone and all of its side effects along with it. Now, before you start torturing me about any possible rejections, I must admit that there are some rejection episodes. In about 85%, the transplant patients had at least one acute rejection episode in the first year. But all of those rejection episodes were easily managed with the usage of high-dose intravenous corticosteroids, mostly prednisolone, and all of those rejection episodes were easily managed and without any problems whatsoever.
Well, so there is a potential risk for acute and chronic rejections. And immunosuppressive therapy goes well with it, that's nice. But the main trouble I see here is actually this patient has to take those medications for the rest of his life. And we know that immunosuppressives have some serious adverse effects like opportunistic infections, diabetes, osteoporosis, neurotoxicity, and most important, cancers. Thank you, Luca. Well, now, this patient has 5 times more chances to get a melanoma. He has 20 times more chances to get a small cell carcinoma, and even 100 times more chances to get a Kaposi sarcoma, so come on. And not to forget the compliance, which is extremely important here and gives us additional problems. And, of course, the enormous psychological stress, for nobody can guarantee the patient will regain his sensation. And after, even if rejection occurs, the patient is again at the start point. So the transplanted hand is functionally inferior, and the restored sensory feeling is usually very weak.
Well, since you brought up the numbers, let them speak for themselves. For example, heart transplant has been here for ages, and a 1-year survival rate of such patients is around 85% or so, and about 75% after 3 years. On the other hand, we have a hand with a 1 to 2 year survival rate of 100%. And this line hasn't really dropped ever since, and it's still more than 95% after all those years. And you also mentioned the loss of sensorics, right? Well, let me start with motorics. Within 5 years, it's practically normal. And what is most important is that they can perform easily everyday tasks without any problems, as you can see in the video, and I've already told you that. And as for sensorics, well, the return of protective sensation is achieved in 100% of patients. The tactile sensation in 90%, and even discriminative sensation in 72% of patients. Now, the techniques are getting better and better, and therefore surgeries and transplantations have much better outcomes. And as of March of 2011, that is the latest data I've got, unfortunately, there have been a total of 70 hands transplanted on 52 patients. Yes, some of them had bilateral transplantations performed, but that doesn't really change much. It has also been suggested that the risk-benefit ratio of such human hand transplantation is similar to that of kidney transplantation because, after all, the immunosuppression protocols used in routine kidney transplantation, hand transplantation are quite similar.
Oh, so many statistics. Well, of course, there is additional challenge of finding a cadaveric donor that suits our patient's sex. If it suits patient's skin color, if it suits the size of a patient's contralateral hand, there are just so many ifs. And look for the expenses. It takes $758,000 based on a 40-year lifespan for a unilateral transplantation. Now, after these things that I've pointed out, bionic hand is simply more reliable. Until 2007, bionic prosthesis didn't have the ability to move every digit separately. And then came iLimb Ultra revolution, the first bionic prosthesis with 360 degrees rotable wrist and thumb. The patient can gradually increase the strength of his grip and has even access to 24 different grips via App Store. So that's pretty cool. Now, it comes with a warranty list as well. If everything isn't working as perfectly as it should, there are mechanics to repair it. It is replaceable. And unlike transplanted hand, it is not receptible yes, for rejections. So there is this one video that I wanted to show you of a guy that lives with his iLimb Ultra for quite some time.
Does it feel the same as using an ordinary hand when you...
Well, I was born without my left arm, so I don't really have the direct comparison. However, what I can say is that this prosthesis, due to the functionality that it offers, has really become a part of my body. So I feel like it's a part of me, and I actually feel that something is missing when I'm not wearing it. Yeah. So to that regard, I think advanced bionic and medical technology can actually become a part of you.
And just one more video with a guy that can tie his shoes, actually, with this bionic prosthesis. Now, I wanted to introduce you to one of the newest studies in this bionic field I was absolutely fascinated with. And this is the project called LifeHand 2. I don't know if you've heard of it. Just a couple of weeks ago in Italy, a research team from different countries developed the prototype of a very first bionic prosthesis with restored sensation. And for the first time in history, the patient with bionic hand was able to feel the shape and the consistency of the objects he picked up and could even detect the strength of his grasp, which is shown here in the video behind.
Yes, yes. All of this is fair and interesting. And right now, I am convinced I do want one of those. But tell me one thing. Where do I get such a nice prosthesis? I mean, in order to acquire one, you either have to be extremely lucky or you have to have plenty of money. We're again here talking about hundreds of thousands of US dollars and more for relatively functional prosthesis, and which is still pretty much the same as transplantation, right? Now, keep in mind that most of the amputees still use traditional hook systems that haven't really changed since the 40s, and they just simply don't do much. Now, all of those new high-tech devices with so-called sensory system that you've talked about are pretty much like those limited edition sports cars. They make 5 of those and then they sell them expensively, and for others, they're out of reach.
Well, let me just remind you, we are talking here about bionics, and since I see you really love numbers, the technology plays a big role in modernizing and improving. And so bionic hand is every step closer to the real human hand. And because it's the method of developing technology, the price has dropped since the first iLimb Ultra launched. So now this iLimb Ultra prosthesis costs less than $100,000. For $60,000 you can get iLimb Ultra Revolution.
Now let's say that we can get a prosthesis ranked somewhere in between. Now the disadvantage of such a low budget arm prosthesis would definitely include, for example, weight. I mean, normally these are heavy due to the materials that are built from, and do not forget they still need some kind of power supply in order for them to function, right? So and at least those batteries should at least last long. Not that you have to charge them every day, just like a mobile phone, for example. And Also keep in mind that these are non-biological elements used, and therefore they are, cannot regenerate as a normal biological tissue would. So they are, after all, susceptible to the environment and therefore in need for frequent reparations. Now, other important obstacle that I see is this compatibility of biological tissue with non-biological elements. There have not been really many studies performed that show that these two things are actually compatible without having any side effects. Now, last but not least, another consequential obstacle, and probably one of the most important ones, is the lack of feedback and control. Robotic arms have no stereognosis, meaning they have no ability whatsoever to know where the limb is located in the space, which would allow the use of the arm in the dark, for example. A robotic arm is, after all, an adjustment, and for many, it still requires a shift in self-image control and expectations.
Absolutely disagree. Charging our mobile phones isn't stopping us from using it. So that's not the problem here. And just the reminder, the investments in this bionic field are enormous. The millions of dollars goes to different research teams all over the globe. And the most important investments in new algorithms and new techniques for sensory feedback. So even from these studies that they are done, that are still in process in Rome, we expect the new published by the end of this month. So everything is so fast, forward moving. So just one more thing here.
Never did I think that there would be a robotic drum arm built. I always entertained the idea, you know, creating my simple mechanic when I was like, oh, this would be awesome if it was robotic and had some myoelectrics in it and all that. And I was like, oh, yeah, maybe one day.
Okay, I feel like I kind of lost this debate, but after all, our major basically points have been presented, and since we're running short in time, we could skip some kind of conclusion and rather ask you the same question we asked you in the beginning. So, which would you choose now? How many of you would still choose hand transplantation? Raise your hand. And what about bionics? Okay, I guess the bionics still wins. So all in all,
our topic today is both depressing and pretty inspiring. It is important to know that hand transplantation and bionic hand aren't suitable for all amputees. Plastic surgeons and psychiatrists must consider the patient's goals, motivations, maturity, intelligence, and of course some physical constraints such as strength, dexterity, joint mobility, pain management, and of course stamp quality. So both sides are on a good way here. Immunosuppression gets less toxic, there are stem cells researches, new studies in bionics. Every day we hear about new 3D printing utility, and so who knows what the future brings us here.
Yes, who knows. So thank you.
Again, first the comments from the mentor.
I have one question first. Is this prosthesis always black or?
No, it is just the most simple one. Not the simple one, but without any customizations made.
Okay, so you get all that motion and all the sensitivity and everything with also the...
This sensory feedback is actually, for now, experimental. Mm-hmm. And so this study isn't finished yet.
Okay, I'm very impressed with that because sensitivity, it's really important, not only for touching, but everything it's more reliable with that. Also the strength of grip and all of that. That's the most important thing, I think.
That is the most important thing that is for these hands, since the hooks weren't so reliable on doing that grip as this one can.
Yes. Anybody has a question from the audience?
Some months ago, there was like a big news because one of the first persons that had the hand transplanted, after some years, didn't feel as the hand was his, and so he wanted an amputation. And I don't know if it's often that a person just doesn't feel the hand as it's like part of himself or whatever.
First of all, I must say that Ljubljana didn't perform any of the hand transplant. So all that I know is from the literature, and I know that the first hand transplantation that was successful was the patient wanted the hand to be amputated again after 2 years, just because of that, because he couldn't accept the hand to be his own. He was every day reminded that that is cadaveric hand, so he wanted to get rid of it. And I think that's an important psychological issue, because I, for myself, I'm not sure that I would be able to integrate a body part of another human as mine. I don't know. That's a big problem, I think. So that's why there are all the psychological tests and everything before that, because this needs to be a very stable person to be able to accept a cadaveric hand. It doesn't mean I'm not stable, but I wanted to say it must be very
strange.
Yes, that's a strange feeling, I think.
I saw in the videos that most of even the two variants managed to have a gross motor skill. But what about fine motor skill? How and when is it? Can it be achieved when there is a hand transplant, and when can it be achieved when there is a robotic transplant? Do you know? Is there any sort of data? For example, I imagine that a patient comes that's a cellist, or tell me an instrument that needs more, not a pianist, but a harpist. So that's really intense fine motor skills a patient needs. And which...
That's a challenge.
Yeah, so can it be achieved with a hand transplant or a robotic transplant? And if it can, do you know when? How much time does a patient need to practice in this? Thanks. Sorry.
Maybe there are some apps for certain songs on the... I don't know. I mean, do any of you know about it? I know that fine motorics is a problem, and it's never the same, I think. Maybe with all the innovation and everything that will be possible, but...
They're definitely going towards the perfection of the human hand, but also there are some serious considerations that just the human hand is something so perfect. It's so hard to achieve.
Luca, do you know anything about the fine motorics?
I haven't found anything on that regard, but so far you cannot really achieve this fine motorics with transplantation. With bionics, a couple of years, years needed. You can actually achieve this fine motorics now, but the problem is, you mentioned the harpist, right? Yeah. That's fast movements, fast and fine movements.
Precise, yeah.
That robotics cannot really achieve right now at this moment, probably in a couple of years.
And just a shout-out question. Do we know exactly why we can't achieve fine motor movements after reimplantation? Are we missing something here? Are we not connecting things properly? The impulses are not being transmitted? What's wrong here?
We have to keep in mind that patients lose their hand, and then they have to wait for another donor to arrive. So it can take a couple of years. And in years, the brain, starts to refill this motorics area of the cortex with something else, right?
But theoretically, if we have donor hand on standby, the fine movements would be more preserved?
I don't dare to say anything right now. Sorry.
I'm just theoretizing.
It's also very complicated because not all of the nerve will regenerate completely, you know, and it's very complicated. A synergy of nerve function, muscle, tendon function. So it's never the same like it was before, right? So, and I don't think ever will be with just with surgery.
Just transplant. Thanks.
Luca, you mentioned some stem cells researches.
Yeah, Barbara mentioned stem cell research, but yeah.
Which direction were you two going in that?
Well, there is a new way while performing the transplantation procedure. You know, we have the donor, you get the arm, and they also take the bone marrow, so they actually perform the bone marrow transplant as well. So this actually lowers the usage of immunosuppressions then. Now they have to take like 2 pills 1 or 2 times per day, but with bone marrow transplantation they can take 1 pill per day, and which suffice for immunosuppression and prevent rejections.
Okay, I have a question regarding the price, or rather coverage of it. You both mentioned that the treatment is really expensive in both cases, so my question is, what does the insurance cover, if anything?
In Slovenia it covers not much. Here's the thing. The insurance covers the prosthesis for the persons under the age of 18. If he or she is studying, then he has to have the status of a student. Then he can have this limit put up on 26 years. After that, no insurance covers anything regarding prosthesis in Slovenia.
I'm not sure.
We haven't performed a transplant yet, and I don't think nobody was sent outside, because you have to have it. He or she would have to move there, because you have to have all the support.
You have to be in the reach, you know, because
at least for 1-2 years to get the. Because Luca, you mentioned that it's only 6 weeks of rehabilitation, but it's actually not. It's a year.
Near the hospital,
it's a year, and I don't know if I remember correctly. It's few months, every day per week, and then every second day in the week, and so on. So it's really, you have to have strong support of that. But I wanted to just to tell you about we had a patient which had an electrical burn, and we had to amputate his both arms in the level of his shoulders. And I think that was 3 years ago, and he received do you know anything about it? He received the bionic, the prosthesis, both prosthesis before a month or 2. And I think both were like 180,000 euros, something like that, but he collected the money for 3 years. So nothing was paid out of insurance.
There is one more thing here. I saw there was just some huge fair in Japan, and then there was this 3D printed hand, bionic one, low budget. So actually it works almost the same as Eileen Bultra, just less complex. And you can get it for $400. That's pretty cheap.
And also a couple of months ago, I don't know if you noticed, there was a big shock because two British people actually decided to remove their hands and replace it with bionic prosthesis because they found it to be better. I don't know. But
a question about mechanics of bionic hand. If perhaps, you know, how does it actually register, you know, the commands, and how do we register the sensory input?
Wi-Fi.
Wi-Fi, but where does it read? Does it read from the brain?
There are different interfaces. 3 are most used. But here for Eileen Bultra, those sensors are on the the residual arm, and then when you have to actually try to make that movement that you want to, so that there is some contraction there, and then those sensors are detecting that and converting it to a movement. It is pretty complex and more mechanics, and I think it's the topic of a broader issue than this.
And the really new way is to use BMI, which is brain-machine interface, with electrodes implanted in the cortex, and they send Wi-Fi signals to the prosthetic arm, and then it moves.
There is Skywalker, I believe, FDA approved just like this month. So there are just so many studies here.
Any more questions?
Anyone? Okay, if not, I would like to thank you again, both of colleagues and the mentor. Applause. Then I would like to invite maybe Alex to have some remarks.
You can stay, we'll do this together.
Okay. That's it.
Yeah, and don't worry, we'll have no big closing remark ceremonies. Oh yeah, best debate. So first, we'll do this Lucky Student Award. Mattia, if you could help me. And yes, Dani. If anybody wants to put paper, you still have time. Last few seconds. Yeah, pick the Mutuki. Huh? Yeah. So Mattia, can you please pick up the first lucky student for Interna Medicina? Well, this is actually Alexandra Filkowska, but okay, so this is your book. Congratulations.
Thank you.
Yeah, and can we call Sandra to take a picture? No problem. We'll do it later.
Okay,
no problem.
thanks.
No problem. And can you do for the stethoscope? Yeah. This is Esther Gagi-Slokar. Okay, thank you, Mattia. That's it. For the best debate, we will announce winner actually at the MSJC skyscraper party. So we'll spare that for the party. Okay? And so let me just finish. Thank you all for coming. I really appreciate the time and the energy of mentors and all students that prepare these debates. I'm glad you come. The very last thing, we really need the feedback, so please can you answer the questions on the evaluation list that you have in your bags. But if you don't have this paper, we'll give you the paper. So this is it. This is all for me. Thank you again. Also all MSJC organizing committee team. Hope to see you all at 9 p.m. at the Nebotičnik. You probably know where it is. It's center of Ljubljana. It will be a great party. First 100 drinks are on us, free, and also we'll have free pizzas. For football fans, we'll have this game will be live streamed. So yeah, and we'll have also a VIP place, and it will be a beautiful view. So join us all for a great party. Invite your friends. Hope to see you in a big number at 9 p.m. at the skyscraper. And that's all. Have a good evening and goodbye. Thank you. Bye.